Thank you, Dr. Asif. So I think
Any questions can be taken on later.
a few questions, clarifications from the audience. Yes. One question. Dr. Asif.
Thank you very much, Dr. Asif, for good presentation. I would like to ask you that does it matter on the position of the incision if you put it the vertical or the oblique when you're harvesting the hamstrings?
Question is on the direction of the incision.
Not at all. Not at all. It is personal preference. For the healing of the wound, slightly an oblique incision looks like it's a little better. But for your exposure, it's just how you're comfortable. Start with a big vertical incision. It's perfectly fine. Get down smaller and oblique as you go.
Right? Or something in the nerve injury.
Thank you, Doctor, for the talk. My question is on the failure rates of ACLs. I think you said the younger the patient and the more active the patient, the higher the failure rate. And I've seen a few surgeons here at Moi also trying to augment the ACL reconstruction with some extra articular methods. What would be your comment on that? And would you have a high index of, doing it in which sort of children or which sort of patients would you do it, and do you do it routinely? Thank you. Just some guidelines on when to do it and how to do it.
Okay. So this is not the focus of this. My talk was primarily on the options of grafts, and this came up. But yes, lateral extraarticular tenodesis is one of the choice interventions of choice when you are suspecting graft failure, and in a younger patient, that's one of the things that's on the books. It is not yet routinely accepted to be doing it, so you may use it if you opt to, but it's not standard of care as of now, and I don't have a lot of experience with it.
But there's quite a bit.
I don't understand. What do you mean by lateral articular? Okay, no. So you're talking of like A, L, and well, that's a good question. Now, when you are dealing with the ACL, number one, you need to grade your ACL rupture. If the pivot shift is 3 plus, Lachman is 3 plus, the patient is young, we need to find out why there is excessive of those signs. Because if you do the ACL alone in a young patient, it will fail. So these are patients in whom maybe the anterolateral ligament complex is torn, or there's a meniscal root tear, or there's a posterolateral corner, and so on. So when you do your ACL, if when you finish there's still laxity, then you must augment this. And the anterolateral ligament augmentation can be done for this. And there are two ways. You can either do an autograft from your hamstrings. If you have used the hamstrings, you can use the remaining part, the gracilis, to do your ALL, or you can use the iliotibial band. Normally I use the gracilis tendon. So augmentation is good. But if you finish and your knee is still lax, your ACL, then the long-term survival is likely to be short.
Perhaps the other thing that we might mention is the use of internal brace as an additive support to your repair or to your graft. That's something that we've also not seen commonly, but it's gaining popularity.
Thank you so much, Dr. Asif, for your insightful talk. I have two questions. One, are there very significant differences in your rehabilitation protocol on your graft choice? Say, for example, if you chose, would you rehabilitate your patients in whom you use the BTB graft versus the hamstring graft? And then, secondly, apart from the obvious differences in the time it takes for the graft to take at the point of fixation, is the process of ligamentization of the different grafts, are there significant differences when it comes to the time period?
Questions.
Yeah. So the first question, for myself, I will tell you that I routinely just use the hamstring graft. I'm not a common, I don't use the BTB, so my rehab protocol is just the one. If I was to do a BTB, then yes, I think I would accelerate the rehab a little bit, because you are getting bone healing faster than your graft is then much more reliable earlier. And that goes to answer your second question, the ligamentization, as you say. So the native fibers of the tendon the native fibers and micro architecture of a tendon is different from that of a ligament, just by the way it is from before. So you expect that to convert faster than you do a tendon to convert. I hope I have answered both.
Thank you, Dr. Asif. Unless if there's any other burning comment or question, I think we'll leave it at that. Thank you, Dr. Asif. Thank you, sir.
Asante sana.
The next presentation, we go to Dr. Timbe. So, Mordecai Atinga, can you hear us?
Yes, morning everyone, I can hear you all.
Yes, good morning. So I think we will ask you to proceed with your presentation so that we can release you to do other things, because it was meant to be at 9. So Dr. Mordecai Atinga is an orthopedic surgeon and lecturer at the Aga Khan University Hospital, Nairobi. We'll be talking about anterior knee pain, very common presentation and important topic for knee arthroscopies. Karibu, Dr. Atinga. You can proceed, Dr. So you can go on, Dr. We can see you now.
Sorry about that, my internet fell out at a critical moment. Just give me 1 minute to share my screen. Hi, Doc. Give me 5 minutes. I have to change my computers. I'm having a problem with my main screen. Sorry about this.
Okay, that's fine, then. We can go on if there are any other questions on the SCF draft. I was concerned about footballers.
Do you do autograph or do allograph?
In Kenya, we all do autograph. We don't have the laws for allograph as of yet. Because you need the choice between a harmful bone to bone and do a bone to bone autograph. Yes, young active athletes, but we don't have the allograph. Any other comment? Question?
Okay, I have two questions. I have two questions. The first question is, we are okay. We are blessed with the with the common graph sources for the ACL. However, I see currently in literature they are including the Achilles tendon, and then they're also including the iliotibial band. Are there advantages with these newer graph sources, or are there failure rates that maybe we don't know about? The second question, you know that there's the gracilis and the subtenonal also have a role in the biomechanics of the knee. Does selecting that graph choice affect your biomechanics, and in what do we just negate it, or it is something we should put in mind that it does the biomechanics? What can we do?
Who wants to answer? The first one is obvious that the Achilles is mainly an allograft. We don't do autograft for Achilles tendon. That is inevitable. The other one problem, especially for very small, but when small hamstrings that cannot be able to sustain the graft, then you have a problem of whether to go to the ortho. Yeah, that's why peroneal tendon becoming a very important. Know that we might end up with another. There's a lot of the way about interfering with the mechanics doesn't arise because most of the graphs are autographs are the exact where we are. We are on the opposite side of where the world is. We are starting with things that will interfere with the biomechanics. The rest of the world does allografts with very good results actually. If you look at the fifth slide, the stiffness and the failure is still higher with an allograft than the native ACL. So you really don't need to do an autograft if you have an option of getting an allograft, because the quality and the outcome is just the strength is twice strength of the native ACL. But what you answered are very relevant concerns.
Well, that was a very good question. It's always, whenever you want to do your surgery, those are the things that go through your mind. How did this patient get the injury? What do they do? What are the activity levels? How heavy are they? What sizes are their knees? What is the likelihood of the size of the tendon going to be? Some more confident. They had a good surgery. You may have wanted to do maybe a hamstring. Do you need to go to the opposite side, or do you look for it elsewhere? As has been mentioned by my colleague, we have those options. But for allografts, I think we really need to move forward. I think there's some steps in Nairobi now to try and get the law changed and set up a bone bank, which of course will include all the tendons and so on. But we are still a long way, because even when you have allografts, how are they collected? How are they stored? How are they sterilized? All these things are going to affect the mechanics, the biomechanics of that particular material. So even when you're reading in a journal that X is better than Y, they can't just tell you this allograft is better than this autograft. They need to tell you when they collected it, how they collected it, how they stored it, how it was used, when it was used, and all those other factors come in. It's not so straightforward. So it's an area where the question is really a minefield. Perhaps minefield is the wrong word. It's a whole area where you need to know quite a little bit about the various issues that are involved. I agree with my colleague completely about the peroneal grafts. They are a little stronger, more reliable, and a little more predictable. And I think most of us are beginning to make more use of the peroneal grafts. Thank you.
We can leave it there. Tina, you ready?
Yes, I am, and apologies for the technical glitch there.
No, you can proceed.
Thank you very much. That's a very stimulating discussion on the ACL options, and I couldn't agree more with what has been stated. Can you see my screen?
You can go to slideshow now.
Okay, I am on slideshow. Is it shown as a slideshow?
No, not yet. It's
bear with me. How about now?
not yet. Still showing everything on the desktop or on the laptop. Yeah. Okay.
Is that a slideshow now?
Not yet. We're only seeing a picture.
Sorry about this. On my side, it's showing that everything is.
Now showing the slide, but not on slideshow. But I think you can proceed. That's okay.
I'm really sorry about this. I can't figure out what's happening in my tech today. I've swapped laptops and everything, but we still have the same concern. Is this adequate? Can I proceed with this?
Yeah, you can proceed. It's clear. You can see.
All right. Thank you very much. Firstly, thank you very much for the invitation, and I'm really upset I couldn't have been there with all of you in TZ today. Unfortunately, I had a commitment that I couldn't swerve. The topic I've been given to discuss is anterior knee pain and clinical presentation and its management. As you all know, this is a very broad topic, and it's something we see a lot of in our clinical practice. So I just thought I'll break it down into very broad categories just to help us get through the topic. When we talk about anterior knee pain, we're mainly focusing on the patellofemoral joint, but this can also include the surrounding soft tissues, and in that we're talking the patella tendon, to an lesser extent the quadriceps tendon, your fat pad and plicae if those are issues at hand. When you're looking at the presentation, I think we approach this like in any other joint in the body. It's a thorough history and a detailed examination. In my history, the three questions I kind of look for is whether they have pain when descending stairs or running downhill, whether they can sit comfortably in the same position, for example, in a car ride going 45 minutes or more. And sometimes they describe instability, which is different from patellar instability, for example, or ACL instability. But they describe positions where the knee is slightly flexed and it gives way. And it's more of a quadriceps inhibition problem rather than a true instability. When I get to the examination after taking the history and understanding what their main symptoms are, you want to check the alignment, and this is both coronal and rotational. So whether they have a valgus attitude, you want to check if they have got pes planus, and you also want to look at the rotational profile of the limb, looking if they have got femoral anteversion and tibial torsion. When you get down to palpation, there's a lot of information that you can get out of a good examination. You can palpate the patellofemoral joint, you can feel the fat pad, you can obviously palpate the patellar tendon, and even a plica can be felt if performed thoroughly. So when we're focusing on alignment, we obviously want to look at the valgus attitude and trying to figure out the Q angle. An elevated Q angle is more likely to cause anterior knee pain, particularly with lateral patellofemoral loading. And like I mentioned earlier, you also want to look at their anteversion and their foot progression angle, because these are all factors that play into dynamic valgus. So when the patient is standing, they might have a normal looking Q angle, but when they start walking, due to the femoral anteversion, you actually find they have a dynamic knee valgus. And this picture kind of shows that, you know, if you picture, typically this would be, it's more common in ladies where they have weak abductors. So when they're walking, the knee kind of collapses into valgus. I mean, not collapse, but moves into valgus. So they have got this dynamic profile where the knee goes into more valgus, whereas if you're watching them standing, it doesn't seem as significant. Again, when you're doing palpation, the two images on the right are showing how you'd pick up Hoffa's fat pad impingement, you know, with your two thumbs pushing either side of the patellar tendon and getting the knee from a flexed position to an extended position. And at a certain point, they'd have discomfort if they're impingement with the fat pad. And that tends to be more on the lateral side of the patellar tendon. The picture on the right, as we look at it, is examining for an inflamed plica. So if you put your two fingers just either side, so on the medial side, which is more common of the patella, and you get the patient to move, you can feel. Sorry?
Your slides are not moving. We are stuck on the first slide.
Can you see this?
You can only see the first slide.
The very first slide.
Yes, that's the only one that is shown. The one with the background.
Can you see anything now?
You can see the one on alignment, examination.
Okay. My slideshow is also not working, so I'm going to have to do this manually, so sorry about this. Yes, so these are the two pictures on the examination. Can you see those?
Yeah, those we can see.
Yeah. And so the pictures on the left of your screen, that's examination for the Hoffa's fat pad impingement. And as I mentioned, so the two thumbs there, either side of the patellar tendon, would elucidate impingement in the fat pad if you're going from a flexed position to an extended position. The picture on the right is palpating for a medial plica, which is the more common one. I'd say maybe 90% more common on the right side. Sorry, more common than on the lateral side. So in terms of management planning, of all the things that can cause anterior knee pain, it's important to have a precise diagnosis, and that's where the history and the examination come in handy. Before we go into more advanced surgical treatments, we have to exhaust conservative measures, which I'd say work 95% of the time, and it has to be patient specific. And obviously, the kind of patients who present to your clinic with anterior knee pain fit one of two profiles. It's generally a very fit, active person, or an overweight, inactive person who might be trying to get fit. So your treatment has to be tailored to the patient in front of you. In any case, we have to start with physiotherapy. And as we all know, quadriceps strengthening is important, particularly focusing on the VMO. Lots of work has been done on that, and studies show the importance of strengthening your quadriceps, particularly your VMO, to reduce the patellar contact pressures and in the long term prevent further cartilage damage. I didn't include in this slide, but it's also critical to work on strengthening the hip abductor muscles, which help control that dynamic element of valgus, which I mentioned earlier. Once they have undergone good physiotherapy and have, if it's the patient who's overweight, they've demonstrated some weight loss, and you've waited a good 6 to 9 months and they're still struggling, then now you can consider surgery. Now, not all patients will be suitable for surgery, and those who are, it's important to figure out the correct surgical tactic that will be adopted. At this point, imaging is important, and one of the most important views you can do when assessing anterior knee pain is your skyline view. The skyline view allows you to check for the patellar tilt and any translation, and patellar height will be picked up on your lateral views, and there are a number of ways of assessing that. You put Insolso-Vati ratios, your Caton-Duchamp, and also MRI indices that you can also use. From the skyline view, you might have one of these patellar configurations. You might have pure tilt, you might have the lateral riding patella, and you might have the lateral riding patella with the tilt. And it's important to pick these out when trying to determine what kind of procedure you do. Equally, you might find the patients who have got normal static alignment. They don't have any tilt or translation, and the patella is at the right height, but they have anterior knee pain, and you've picked up either patellofemoral irritation. When all else fails, you can have an arthroscopic intervention. Of the two images, I hope you can see this. The one on the left shows what a plica looks like. Now, this is a common finding, I would say, arthroscopically, and you don't necessarily have to deal with this, but in a patient who comes with anterior knee pain and you've exhausted all conservative measures and the examination suggests that the plica is the issue, you can arthroscopically deal with it. The image on the right shows what typical patellar chondromalacia looks like. You have the damaged articular surface and these loose hanging fronts. Arthroscopically, you can deal with both. You can either perform a chondroplasty. I don't know if this shows clearly, but the picture on the top, you go in with a shaver and you just shave off those loose hanging fronts. When I'm dealing with my patients, I tell them that it's a 50-50 operation. There's no guarantee that that's going to improve their symptoms. But in a patient who has tried everything, this is a useful intervention and often improves their situation. And equally with a plica excision, you can shave that arthroscopically, and it's a very easy operation, and if in the right patient, can be very rewarding. Now, the guys who have the patellar malalignments, you now need to think about what your options are. In a patient who has got focal lateral patellar pain and the lateral tilt, the lateral release is a reasonable operation, and you go and you release the lateral tissues. I don't know if this shows clearly, but the top right part of that picture is showing the patella, and that's with an arthro wand, and you're just shaving off the lateral patellofemoral tissues, allowing movement of the patella. In the right patient, it's a very rewarding operation, but once again, if you do that in an overweight lady with valgus and loose tissue, you might be in trouble. In the patients who have got maltracking and patella alta, you can consider osteotomies, and this works, you know, in the image where they have a lateral riding patella and they have got patella alta. Tibial tubercle osteotomy with medialization, anteriorization, and distalization is a very effective procedure. Obviously, patient must understand that it's a long journey. It will take at least 6 weeks in a brace, another 6 weeks of early physiotherapy before they even start thinking about getting back to their activities. But it's a very effective operation, and this is one we did where we just simply anteriorized and medialized the tibial tubercle. In patients who've got severe coronal plane malalignment, distal femoral osteotomy is also very effective. This is one case we did, but this was for a patient who had more instability, which I know we're going to speak on later, so I won't focus too much on this. And more advanced options are looking at chondral replacement operations. We don't, at the moment, have these regionally. You need special labs where you can culture and grow your chondrocytes before re-injecting them, but that's what the procedure would look like, and it's, as you can imagine, a fairly committed approach. And then you can also have combined procedures where you do both the osteotomies to correct the anatomical disadvantage the patient would have and chondral replacement. And there are lots of studies that have shown good outcomes in realignment operations, both in young and old patients, as shown here. So in summary, anterior knee pain is a very broad topic. It's something we see a lot of, and very few patients will end up in theatre. But it's still extremely important to have a thorough assessment. Take a full history. Your examination must be thorough. There's no treatment that fits everyone. It has to be very patient-specific. Cannot stress enough the importance of exhausting conservative treatments. And in any patient who comes to you with anterior knee pain, before you look to surgery, I would advise you at least have 9 months of non-operative interventions, including physiotherapy, injections. Get to know your patient well and understand what their motivations are. And once you do come to an operation, you must pick the right operation. And as you can see, there are numerous options. Sorry about the technical glitches, stuff like that. Thank you for your patience, and I'm happy to take some questions.
Thank you. I think I will invite some questions from the audience. Anybody? Start from the back.
Thank you, Dr. Tiga, for the excellent talk. I'm not a typical knee surgeon, but of course we see patients with anterior knee pain and then we send them to the physiotherapist. But I'm just wondering, because sometimes the physiotherapist actually asks you, what do you exactly want me to do? I saw a typical patient, female, who is having pain when ascending stairs or sometimes descending stairs, and then you just send them to the physio. But exactly what do you want the physio to do in order to alleviate that? I mean, I know that sometimes they talk about quadriceps exercises to lift the patella off the femur. I just want some, some light on that. Thank you.
Thank you very much. That's a great question, and it's really important because I think we all fall victim to sending our patients to the physiotherapist and letting whatever happens. And like you rightly point out, I have recently become more specific in what I request. So I ask the physios to first start on working on their quadriceps and hamstrings, focusing on the VMO. I advise them to avoid any exercises that involve deep squats. I also want them to work on their hip abductors and the gluteal muscles. And it's really important for the patients to have a home exercise plan. One thing you often find is when the patient will come back to you 5 months later with ongoing pain, and the typical story will be like, I did 6 sessions of physiotherapy and it made no difference. And you know what I tell them is, you can't go to the gym 6 times and look for bigger biceps. You know, this is a journey, and so it is so important that they work on the whole their whole profile. So VMOs, quadriceps, hamstrings, gluteal muscles, abductors, avoiding deep squats initially. I also tell them to get onto a bicycle machine, low resistance, high cadence, 20-30 minute sessions. They must incorporate rest days, so if they can do 2-3 sessions a week. I also advise them to get onto a cross trainer, the same thing, low resistance, almost more like a cardiac workout for them. And it's also important to warn them that even if they're doing all the right things, you only start to enjoy the benefit of your physiotherapy regime after 3 months. And initially, the knee will get worse before it gets better when you start working out. And these are really important points to point out to your patients so that they comply and keep going with the physiotherapy. And it goes without saying, weight loss also matters. It's more difficult in your sports person who has got no weight on them and they come with anterior knee pain. Those are the guys who are really challenging. And for those, I leave it to the physios to try taping. There's some interesting knee braces that are being launched. You know, there's one called the reaction knee brace that they say kind of reduces the patellofemoral contact forces. I'm not sure, but it's worth trying, especially in that difficult subset of people who is the active sports person who is not overweight and has got excellent quadriceps and gluteal muscles. And that's what I meant about trying to tailor it. And in those guys, I have a low threshold for offering them injections as well. But yeah, give a fairly specific plan to your physiotherapists. Reassure the patient, tell them it will take some time and it will get worse before it gets better.
As we head to another question, your comment on VMO deficiency type 3, the ones without complete lack of VMO, and the role of tropioplasty.
Sorry, the role of tropioplasty.
Question. Let's take this question, then you can.
Okay.
The others you can comment.
Thank you so much. Is there a role for MRIs in the investigation of these patients with anterior knee pains?
That's a good question, and the reality is we can make most of the diagnosis in patients with anterior knee pain with a good clinical examination of the history. But I think with the increasing availability of MRI scans and patient expectation, I admit I've got a very low threshold for doing MRI scans because the patients expect it. But it is useful. MRI scan would show you patellar tendinitis. It can show you fat pad impingement. It will show you control damage of the patella, and can also help you grade it. I find it particularly useful if you do an MRI scan in someone who's got patella alta, and you know it shows you that they've got inferior pole chondromalacia, and the superior pole is normal. In that kind of patient, I'd have a very low threshold for offering them a tibio-tubercle transfer to distalize and medialize, because you know that person will do well because you're taking the area in trouble out of the high pressure zone. So there's definitely use for MRI scan. I have to admit I use it more than is strictly necessary, purely because it's increasingly become part of your patient treatment protocol. They expect it.
Any comments?
Well, I agree with you, Mordecai. However, MRIs show you so many things. So unless you know what it is you are looking for, you are likely to probably assign that pain to something else. So the challenge is to have a clinical impression of what it is that you have diagnosed. And then when you do your MRI, it confirms what it is that you found. Or else it's very easy to be misled. That's my view.
I couldn't agree more. That's right, Dr. Mutiso.
A lot of them will have chondromalacia as the MRI finding. How often do you do arthroscopy for chondromalacia?
Much as I've given this talk showing all those surgical options, I would say in the last year, I have probably done one. And that points to the fact that if you're doing many arthroscopies for chondromalacia patella, you're on the wrong track. It's an easy operation to do, but rarely is the clinical need that often made. So it's a very rare thing I do, and I'd be worried if someone had a list full of arthroscopies for chondromalacia patella, and I'm sure everyone would agree with me. Most of the times, this is a problem that's managed conservatively, and there are a number of options available to us. But the patient who has done everything is stuck and comes through it. I would. So I was recently just reviewing my the operations I've done for just a pure chondroplasty in the last 5 years. I've done maybe just 6. 4 of them are happy, 2 of them are not, which is a poor success rate for any operations. But I'm confident in having done it because I know they've gone through all the other steps and they're nothing to lose by the time we did the arthroscopy.
Thank you, Dr. Tinga. If there's no other question, we will release you to do other things.
Thank you very much.
We'll proceed.
Thank you very much.
So I think we'll invite Mark McDonald. He has 2 presentations. One, you mentioned on the role of orthobiologics, and then he will focus on arthroscopic chondropathology management. It was logged in. Now there's nobody logged in. When he logs in, we can.
He's logging in. But if he logs in, then we probably will be done with orthobiology. I don't think he's ready yet. Maybe he's having challenges.
You can give the first talk on orthobiologics. Give him 5 to 10 minutes.
Yeah. Good morning. I'll proceed with the talk on orthobiologics as we wait for Dr. Baraza to log in. I must disclaim that I am not. I think this issue of using orthobiologics, there's 2 types of orthopedic surgeons: the ones who agree with it and the ones who are not so much into orthobiologics. I think I've realized that there's a lot of money in it, orthobiologics, and so for the young colleagues, it's something worth thinking about, because I have noticed sometimes in our hospitals doctors who are injecting knees, shoulders, hips, they have more patients than the ones who are operating them. So, and because most of the there is no real target to what you're aiming for. I think most of the time I say the target is the money more than the end point of the patient being sorted. So you sort of get away with it. Give the injection, you get away with it. You can tell the patient, yeah, we thought it would work, but it doesn't. So now we can proceed to surgery. So there is two types of us: those who do orthobiologics practice almost exclusively, and then the other people who don't believe in it and we operate. I don't know where I belong, but I rarely inject these joints. But I'll talk about it anyway because my colleague was supposed to talk about it. Was not able to, Dr. Shamshuddin. I think the most rudimentary of orthobiologics that you never think about it really is when you're doing a bone graft. When you're doing a bone graft, you harvest bone and you put it at a fracture site, whether it's fresh or it has not united. It's some form of rudimentary orthobiologics to begin with. You're trying to change the biology of the area where you're working to enhance healing and the way the bone graft works by inducing bone formation, encouraging the biochemical environment that helps the bone to heal is some form of at least the early orthobiologics topic. But now we have evolved into trying to, now that we know that bone graft works, we know bone graft works in many ways, by giving you a scaffold, by reducing the strain at the fracture site, and by giving you the kind of cells that work. Now people have gone further to purify what it is we believe the bone graft contains, and now those purified products are some of the things we might be talking about today as the advanced practice of orthobiologics now. So then you can imagine that the role really of orthobiologics is to help us to cause healing or to regenerate tissue. We just tell the patient is early osteoarthritis. Then the patients get shocked because patients think a diagnosis of osteoarthritis is almost like you have TB or something. I don't know why people think like that. Tell them, no, but even me who is telling you I have this. So we are on the same path. They're like, is there anything I can do to reverse this graph? And then I tell them, the day we discover that drug is the day I will close my clinic, because that is the only thing I treat. And then they think maybe you have the drug, but you are hiding the drug so that you can continue seeing them. So orthobiologics are a threat to our practice, maybe. We apply them in treating osteoarthritis. We'll have a small discussion on that. Tendon inflammations, ruptures, fracture non-unions, avascular necrosis, cartilage injuries in sports medicine, and when we do meniscus surgery. So in bone healing, what do we do? I mentioned the bone graft, which is simple. But sometimes after you brought the fracture, so when you have a fracture that is non-united, even if there is an implant in place, you do not necessarily need to change the implant. For example, you can put a screw across the fracture, or you can drill at the fracture site and inject bone marrow down there, or you can put a bone graft down there. Not always that you need to change the implant that is fixing the fracture. Sometimes it is the strain environment that is not favorable for this fracture. And a lot of studies happening on non-unions and what you can do around the fracture. But some of the things you can use is demineralized bone matrix, which is really allograft. That is demineralized, or you can use bone substitutes. And you know about recombinant PTH. Recombinant PTH is part of hormone in microdoses of like 20 micrograms injected. So if you think a fracture is going to give you problems healing, these days I'm having a low threshold to start patients on parathormone immediately when I see that the fracture is going to give me problems. We have a few in the market. After fixation, let's say I've done multiple, like shish kebab osteotomies for somebody who had a crooked bone or something. I will start the patients on recombinant PTH, 20 micrograms every day. You know that this is a hormone that encourages bone union. It also used to treat osteoporosis. I don't know mechanisms that are a lot of discussion still happening, but sports people, when they get a fracture, like Ronaldo gets a fracture, they fix him, and they put him on recombinant PTH, and in 6 to 8 weeks, the guy is back playing. You're wondering how fast he healed. So now it's no longer off-label. It's now official that you can use recombinant PTH to encourage bone healing. For articular cartilage, again, Dr. Tika presented a picture there where they had put a membrane and injected the stem cells. We are using bone marrow aspirates, and in fact, the whole concept of meniscus surgery and articular cartilage repairs, when you find somebody has repaired the meniscus, then he goes to the notch. You remember yesterday there was a video, there was a notch plastic with microfraction. What they are trying to do is to bring in bone marrow stem cells from the bone marrow to encourage that healing of that meniscus that they have repaired. And where you can source this from the fat cells, which is adipose derived, or you can source it from blood. The other things about articular cartilage is osteochondral allografts and autografts, and MESI. MESI and AC, these are cells. They harvest some cartilage from some non-articular areas, fish out the chondrocytes and go and culture them in Germany, and then bring a membrane of them and put back where you have a defect. This people claim that it is very, I think it's very expensive because it takes like 6 months. They used to do it in Europe. There are doctors in Europe who specialize in cartilage regeneration medicine. I don't know about America, but I know quite a few in Europe. So these guys are very expensive doctors. What they do, they scope your knee, they find chondral lesions, they harvest cartilage and go away with that cartilage in Germany. 6 months down the line, they call you, come back for a scope. Now they have a membrane they have been growing in a lab in Germany. It's very expensive medicine, but I don't know whether they have published their outcomes, but they say that it works for cartilage erosions. And then PRP. I think for us, most of the game surrounds around PIP and whether we can use this PRP to improve outcome, to improve outlooks of osteoarthritis. So for us, I think I'll have a little talk on chondro injuries then I'll explain how we use these biologics also. So the precautions in this biologics practice is that the outcomes are not definite. They are not definite. And I listened to someone who was saying the problem in medicine, if a treatment works, then it is okay. You give Panadol the way I say it, and you know it treats, and it works, it is very nice. It is clear, no controversy. If a treatment causes harm, for example, we give Vioxx, and Vioxx causes side effects, we stop Vioxx because everybody knows. The problem, and where money is treatments that don't do nothing. Treatments that don't do nothing, nobody fights them because we don't know, and the people who sell them say they work, and because we don't have proof, nobody can fight anyone. And so these treatments tend to last on earth for very long. And I'm not saying anything. The side effects are specific usually to the one you're using. Sometimes these are animal sourced and they can give you infections. I don't know whether you guys have read the microbiome theory from the guys who do joint infections. Pavisi talks about microbiome theory, and you guys are aware that people are even saying now you can use these things we take when you have diarrhea. What are they called? When you have diarrhea, they give you bacteria, lactobacilli. You know those sachets you take for changing the flora in the. You know, people are now saying those things also help even in arthritis, apparently. So if you listen to Pavisi, you might not continue laughing. You might continue listening. That they now believe that the whole of your body is full of bacteria, even inside, even in the joints. You have bacteria. It's just that you coexist with them in a very peaceful way. When there is an imbalance of some kind, so I think the surgeons are trying to run away from infection. When you operate a joint against infection, now we will be saying, due to the from the microbiome theory, you have bacteria always in your, so it's not the surgeon who causes the infection. But they are now saying that if you use these oral whatever sachets, apparently they can reduce even the chances of you getting infection or you getting arthritis and stuff like that. I think it's something worth listening to, the talk by Pavisi. Then the other thing is the cost. They are very expensive, these things, because you have to acquire the machine. And so when you run it, when you get into this practice, you need to know that your patient, you're costing your patient for something you might not quantify. So we cannot fight nature, and yet we must accept what nature gives. Thank you very much. I don't know if Baraza has lobby. Are we able to see?
Can you hear me? I have.
Good. So let me allow Baraza to share his. Can come and assist us. Jale, you are welcome.
Thank you very much. Thanks for your talk, Tommy. May I share my screen?
Go ahead, Dr. Baraza.
Can you see it?
I can see it very clear.
Okay, and can you hear me clearly? Can you all hear me clearly? Is that a yes?
Yeah, we can hear you clearly.
Excellent. Okay, so I'll start if that's okay. Thank you for inviting me to this meeting, particularly Dr. Muchomi, who extended the invite to give this talk on ACLs. I work at Aga Khan Hospital with him, and sorry?
You are not very audible. You can add a bit of volume.
Okay, one second. Let me try and change my. What about now?
That's perfect.
Is this better?
Yes, much better.
Okay, excellent. So thank you for the invites, and for it's a pleasure being part of the East African Arthroscopic Association meeting. I'm going to talk about pediatric ACLs. These are some of my affiliations. Now, as we all know, ACL injuries occur when pivoting takes place, and there's swelling, instability, and quite often you need an MRI to confirm the diagnosis, and it looks something like this, though it isn't always clear-cut, so it's very important that we use our clinical acumen as well, not forgetting the Lachman test and the Kovachev test, although we have to be quite gentle when doing it in an acutely injured knee. Now, do young people with ACL injuries need surgery? The answer is almost always yes, unless there's an extremely compelling reason. The answer is yes. And what are some of the pre-surgical considerations? So, how young is the child? A child of 6 and a child of 15 are completely different. About the age of 14, 15, you can treat them as an adult, but at 6, there's physio considerations. And then, of course, there's anesthesia, operative technique, skin numbness, where the inferior branch of the saphenous nerve is, if you're doing the SEMI-T harvest, postal pain. This is all in common with most ACLs, but the one I really want to focus on is re-rupture. So we really have to consent the parents and the children themselves that the younger you get your ACL injury, the higher the rates of re-rupture. Now, these are the power of the physis. So the distal femur and the proximal tibia are among the most powerful growth plates in the body. So they need to be considered when reconstructing ACLs in children. Drilling through a physis will lead to bleeding, and then it can lead to a bony bar, and that can cause either angular deformity if that is eccentric, or growth arrest. So this is one of the most important considerations. And then if the surface area is greater than 5%, it can cause arrest. Thankfully, an 8mm drill almost perpendicular to the tibia, is only about 4% of the growth plate, so it's unlikely to cause any growth arrest. So we need to keep these facts in mind. These are some of the techniques. It doesn't quite project well, but there's the physial sparing over the top, and then there's the partial transphysial, and then there's the normal one on the right, which we use for adults. Intraoperatively, in addition to the usual supine, tourniquet, anesthesia, where I trained, we use a semi-T and gracilis harvest, although one of the other surgeons who I didn't actually work with used iliotibial band. Standard preparation of the graft. The important thing is that the graft is long enough to go through the tibial tunnel. That's the most important thing, whether you're doing an all inside or the semi-T bundled over in 4. In terms of the femoral preparation, this is one of the most critical steps. So it's important that we fudge the jig. So on the image on the left there shows the jig and the guide. So here you always have to use the flip cutter. So as you're putting the guide wire, you have to use image intensifier, a small wire, and make sure that the wire is sufficiently distal to the physis. Small diameter is good. So when you're preparing the graft, as I'll say, small diameter is actually better. So the tunnel should look something like this, distal to the physis. And then next, the tibial preparation. So the native footprint is found, which is pretty much adjacent to the anterior horn of the lateral meniscus, or just lateral to the medial tibial eminence. You want as steep an angle as possible to reduce the surface area of the tibial physis that's been destroyed, as it were. And it normally goes through the middle, and it's a small surface area. So we said we want a small graft, so 6-7 millimeters should be absolutely fine. And it's, as I mentioned before, it's of critical importance that the graft traverses the tibial physis. Passage of the graft is in the usual fashion, introducing it into the knee. We use a tightrope at the femur, and then a screw at the tibia. So you want a fairly short screw because you don't want it in the physis. Now, we don't want to over-tension the graft. So I don't think we need to do a reverse Lackman's. There are a few reasons we don't over-tension. Number one is the graft might fail quicker, but number two, you might actually tether the growth plate because you're coming in quite vertical. So we want to put optimal tension. It's a bit of an art. Post-op standard, we have to focus more on pain relief than the adults. So lots of blocks, a finished block, local anesthetic within the knee, although that's controversial in terms of the effect of the cartilage and the graft. We'll check in a couple of weeks, and we want to rehabilitate them intentionally, very slowly. We need to stiffen up a little because children are naturally quite lax, so we don't mind the knee stiffening up a little. So typically we do closed chain exercises. That's where the distal extremity is fixed and the knee is moving. They should be walking independently at about 3 months, fast walking at 6 months, jogging at 9 months, pivoting at 12, and return to sports at 15 as a general rule. Although many children do a lot better than these in terms of meeting these milestones, but we don't want to encourage them to. Now, what are some of the complications? Re-rupture, as I mentioned, is big. The younger the child, the higher the chance of re-rupture. Nerve damage, that's the infrapatellar branch of the saphenous. As long as you explain to them that there might be some numbness there, it's usually not a problem. Now, genovalgum, if you drill through the lateral aspect of the femur, it could heal, form a bony bar, and then there's growth from the medial side that leads the limb into this valgus malalignment, which not just changes the mechanical axis deviation, but also may lead to patellofemoral instability. The other consideration is tibial recurvatum. So if you put a screw through the tibial hypophysis, the anterior part stops going, the posterior part continues, and you get this deformity of the tibia. So it's important that you come very steep and very long, so you make sure that your entry to the tibia is distal to the tibial apophysis, or where the patellar tendon inserts. So in conclusion, there is do what you normally do with ACLs. There's one of my old preceptors used to say, don't change what you normally do. Do what you normally do, but just make slight adjustments on the situation. So remember, there's a growth plate. Try and avoid it, especially the femur, where you can get the eccentric bony bar and genu valgus. For the tibia, try and come straight through the middle. It's a small surface area, and as long as graft goes through it, we're happy. Small tunnels is good. We're happy with 6 and 7 millimeter grafts. Do not overtension, because it could lead to graft failure, but more importantly, it could lead to graft disturbance. Follow-up is critical because we want to, in the unfortunate event of any limb malalignment, we want to make sure that we pick it up early and we intervene to correct it. Thank you very much.
Thank you, Dr. Baraza. Any questions? You can hang on for any questions or clarifications. Yes. So we have a couple of questions.
Thank you, Doctor, for a very good talk. I've got 2 questions. The first question is about how technically different is trying to avoid the physis, because I saw some of the pictures. The tunnel in the femur, for example, seems to be quite acute, turning an acute turn, trying to avoid the growth plate. So just wanted some thoughts on the technicality of doing that. Then the second question is about, in our talks here, we've been told that when children play, so they're always playing, they're always jumping around, and we briefly talked about some anterolateral augmentation, extra-articular augmentation, to try to protect that SCF from re-rupturing. Just wanted some thoughts on that and the indication for that in children. Thank you.
Yeah, those are great questions. So for the first question, the femoral tunnel, yes, absolutely, I completely agree with you. If you're used to doing adult ACLs and just going straight through, you're used to long tunnels of 35 millimeters, sometimes even 40, 28. But in a child, because you have to almost fudge that jig distally, you get used to slightly smaller tunnels. So 15, 20 is the norm. And it's quite frustrating because you almost have to sacrifice. I guess this photo at the bottom there shows that what we try and do is reconstruct the anteromedial bundle of the ACL. So you almost have to sacrifice the position of the graft precisely in order to avoid the physis. Sometimes it's unavoidable, but with experience, it comes. After you've done 2 or 3, it gets easier. But yeah, the first few times it can be quite a frustrating process because you're used to the adult ones. But it's almost worth trying to err a little bit towards the posterolateral bundle reconstruction just to avoid the physis and make sure that you distal to it. It takes some practice. The second question was anterolateral ligament reconstruction. Yes, that's a fairly hot topic. It was in the unit I worked, it was only used in revision ACLs. For primary ACLs, it was always just semi-T and gracilis or ITB graft. Now, for revisions, yes, we harvest a bit of the lateral ITB and then staple it back down after passing around the lateral collateral ligament. I don't know, I have to confess, of any studies that show it's beneficial in primary ACLs in children, but then again, there's so many confounding factors in these, even in the studies in adults, because no one quite does the same rehabilitation protocol. No one, it's almost impossible to standardize all patients, and what one person may have thought was rupture because of inadequate support, another person might put down to inadequate, hamstrings or quads tenderness. But I think that's an area of research that high volume centers should engage in. Absolutely, it's an excellent point, controversial one.
Yes, thank you very much. I have 2 questions. The first question, does the orientation of the ACL graft alter your biomechanics like when you compare adult ACL reconstruction and then the children's ACL reconstruction, that's the ACL orientation altered by mechanics. And then the second thing is we know the ACL during the growth spurt increases in length and width by 0.4 millimeters per year. So does the ACL graft adapt to a growing child? Because we expect most of the injuries to happen between 10 to 16 years. So during that time, there is a growth spurt for most children. Does the ACL graft adapt, and does this adaptation failure to adapt maybe lead to failure?
I'll start with your second question. So that's part of the reason why ACL reconstruction is so fascinating, is that we use tendons, and over time, and that time is thought to be about 1 year, that tendon actually becomes ligamentized. So the change in there's metaplasia of the fibrocytes, of the fibroblasts and all that. So it becomes more like a ligament. And it seems that reconstructed ACL acts like a native ligament, which is brilliant, because even the ACL done in children as young as 7 and 8 years old, when they experience the growth spurt, it doesn't seem to tether the growth in the majority of cases, or cause any kind of knee tightness or altered biomechanics. So that's actually pretty fascinating. And then the first point you're making was it was something about the orientation of the ACL altering the joint mechanics. I didn't quite get it. Do you mind repeating the first question?
No, I mean there is a price to pay, because the aim is to try to avoid injuring the growth plate. But I'm seeing the ACL seems to gain an acute orientation, which is a bit different from the native ACL. Does trying to avoid the growth plate have a price to pay in the biomechanics of the knee later on?
So the most important consideration is where the graft enters the femur. Yeah. So as long as the graft is in the anatomical area of the anteromedial bundle, which is just posterior to the intercondylar ridge and the bifurcate ridge, then it is okay. What is actually happening inside the positioning and all that is just the mechanical tethering. So no, as long as you get your positioning right, it doesn't seem to have any effect. Although I do take your point that it seems to take a bit of an acute angle, but that's a lot of the reason why we want to take them slow, because we want that scar tissue to form, we want it to become a ligament. So as long as the rehab is okay, it doesn't seem to have any effect, a major effect, I should say, on the biomechanics of the knee. The other thing is that children seem to adapt pretty well, because even the rates of re-rupture are not as high as you would have, as you would think, that given that they've got another 60, 70, 80 years to live. So they seem to adapt very well in terms of the hamstring strength, length, tension to protect the graft. So it's actually, yes, there is a small price to pay in terms of avoiding the physis, but as long as you're in the ballpark area, which is as long as you know where it is, it can be comparatively large, considering you're putting a small graft, it's not too much of a problem. Very successful procedure. Children are delighted with getting the knee stability back.
Thanks, Baraza. One more question is, just how much do children inspire primary repair of the ACL as opposed to reconstruction? I would like to know whether you guys who do children sports are more inclined to primary ACL repair or not. And number two, when you do that vertical drilling of the tibia, do you advise that you can use a bioscrew to anchor it, or you must keep away from a bioscrew and anchor in another way?
Again, real good questions. For the first question, the repair of the ACL. When I was just finishing my fellowship, one of the sports people was actually convinced that If it is almost like an avulsion off the bone, then that was amenable to repair. So, you can rip it with a arthric suture and reattach it on. He had only just started exploring that. I should get back in touch with him to see whether he's started collecting numbers. He was a very high, he had the privilege of being an extremely high volume surgeon. So he had the luxury of, experimenting and trying. It's not something that was widely, when reconstruction is so successful, it's difficult advocating. I guess that's one of the drawbacks of ethics and research. It's difficult veering off a tried and tested routes. So I think it can be viewed as experimental for the time being. It should only be done as part of a study. And then the second question you're talking about is the tibia. So we always used to use a screw, but a short screw. So you've come quite distal in the tibial jig. So you're distal to the tibial and distal and slightly medial to the apophysis, and you try and get right in the middle of the native footprint, and then you use a screw. It's fine as long as the screw is sufficiently short. 18, 20. It's not a problem at all. You just need to make sure that the graft is going through your tibial-physial drill hole. That's the most important consideration, and keep it small. So using a screw is absolutely okay.
Thank you, Dr. Baraza. One last comment. Thank you very much, Dr. Baraza, for presentation of ACL in pediatrics. What's your experience of overtop procedure with the ACL in pediatrics?
So a total procedure.
The overtop femoral procedure.
Oh, over the top. Oh, yes. Yeah. No, I'm really glad you asked that, because I'm going to say something which I hope there's no industry people in the room. One of my old fellowship guys at when I was doing my arthroscopy fellowship, he had like 30 years experience of doing ACLs. And they used to, granted it was in adults, so they used to leave it attached to the tibia, harvest the semity gracilis, make the tibial tunnel, bring it over the top, and hold it with a staple that costs about $60 US. And he said that though the graft was thin, it was absolutely fine, and all the patients did very, very well. It's almost like the one in the partial physial. Now, with the advent of industry, they said, oh, we have to use all these fancy tight ropes and all these, suspension techniques. And if you're not using them, you're seen as uncool. So it seems that we, as arthroscopy surgeons, have all moved towards using all these fairly expensive bio screws and suspensory mechanism, Chinese finger trap. And that's, I have to say, I'm embarrassed to say, I haven't done it over the top. But from the people who used to do it, the experienced surgeons, they say that it worked absolutely fine. And I think if you're in a resource-strained environment and you don't have all the fancy stuff, I think you're more than, by all means, harvest, make a small tunnel, bend over the top, hold it with a screw or staple. I think that's a perfectly acceptable way of doing it. I'm just, like I said, a bit ashamed to say that I've never done it, but hopefully before the end of my time as a surgeon, I'll have done a few. But that's actually to be encouraged.
Thank you very much, Dr. Baraza. Please, if we inform the team, we go for tea break. The tea is ready. The venue is same as the venue of yesterday. How many minutes, Dr.?
cartilage, 60% of the composition is collagen. The current available therapies which are available in the market, like glucosamine, chondroitin combinations, they take care of the protoglycan levels. During our joint distress, the protoglycan our joint automatically produces protoglycan levels. But what it is not able to replenish is collagen levels. So this is where we are going to work on Parkinson's. These are the current therapies which are available, very commonly used, like non-steroidal incumbent drugs. This is the synthesis and decrease of degradation of collagen. This is the most important part. Whereas glucosamine is not getting work at this level. And also increases the protoglycans and hyaluronic acid levels. And should be safe for long-term use also. So introducing Cartiflex. This is the brand for collagen peptide for the management of osteoarthritis. The collagen peptide, it helps to synthesize it and prevents the degradation of collagen levels. It helps to rebuild cartilage. Reduces inflammation, reduces hyperplasia. This is the only product collagen peptide which has been proven. We'll see in the subsequent slides that after 3 months of therapy, the requirement of analgesics decreased by 75%. Also increases the synovial fluid and inhibits the differentiation of osteoclast and increases the bone thermal. Now I'm presenting the clinical evidence. This is a study which was conducted on collagen peptide on around 250 patients with the average mean age group was 59 years. And the condition was, the VAS score was between 30 to 50. After 6 months of therapy, it has been found the reduction of greater than or equal to 30 millimeter of reduction in VAS score. So this helps patients to improve their normal functions and improvise the daily activities and physical activities of the day. And oral supplementation of Cartiflex significantly This was another study which was conducted. The study is called Delayed Gadolinium Enhanced. This study, this is MRI scan on 30 patients who were taken before treatment and after treatment. If you see the next slide, this is the treatment of the study on the cartilage of without giving collagen peptide. If you see, the disease progresses over the period of time. If you see after 48 weeks, the green part, which is the collagen and the cartilage level, starts turning into reddish form. So this is a deterioration of the cartilage which is happening. But when it was this same patients were put on collagen peptide, the cartilage levels start turning green, shifting to green conditions. This improves, this helps it Cartiflex improves the overall health of cartilage. It prevents degradation and helps in synthesis of cartilage. So the conclusion is the treatment adherence was 96.2%. There was no discontinuation of the therapy and detected apparent change in cartilage proteoglycan concentration just within 6 months of therapy. Now this is the study which was conducted. This is a direct comparison with this Cartiflex, that is collagen peptide, versus glucosamine and chondroitin. If you see that here the outcome was measured in terms of SF36 score. If you look at the next slide, this is the comparison with those patients who are on collagen peptide have shown better improvement in decrease in pain. Whereas with glucosamine group of patients, they were only negligible number of patients shown improvement, which is marked in the red circle. And also helps, collagen peptide also helps to improve the overall physical activities, mental health, physical and social functions, emotional health, all aspects with collagen peptide. The most common side effects was reported with glucosamine chondroitin combination, dyspepsia, gastritis is more common, and glucosamine is also not recommended. It is not advised for diabetic patients because of the So Cartiflex, this is to conclude, the Cartiflex overall improves it is a disease modifying agent, so it decreases the deterioration and degradation of cartilage, prevents collagen degradation, which is not seen with glucosamine chondroitin. Proteoglycan synthesis were higher in collagen peptide group. Patient compliance was better. And collagen peptide is the GRAS approved, which is US body, which is recognized as a generally safe to treat, to use, and is also recommended by experts now. And those doctors who have tried, even in Tanzanian population, it was found that this product has shown a good efficacy. We have procured raw material from Germany. It is trans, BSE risk free, GMO free, and also it's an halal certified. Cartiflex is sugar free, trans fat free, BSE risk free, and this is a 10.2 grams sachets. It can be used by dissolving a glass of water, around 200 ml glass of water, and it's available in delicious orange flavor. Thank you so much. If you have any query, we are there. You can just come and meet me and we'll answer them. Thank you so much.
Thank you, Mr. Singh, for keeping time. Any questions for Mr. Singh? Thank you. If you have questions, you can ask them in the display area. Thank you for sponsoring the meeting, IPCA. Now we would like to welcome Dr. Owinga. There is a series of lectures we missed yesterday. We'll try to catch up. 10-15 minutes, 10-15 minutes of each. He has two presentations, but we will break one and then another presentation from someone else, and Dr. Wino will come back again. So I think we start with the radiological evaluation of the knee.
Just to mention that Dr. Inga is the chairman of East Africa Arthroscopy Association.
Thank you, Mungu. Thank you very much for welcoming us to Dar es Salaam. This is our second time. And we wish to thank Nungu. Nungu comes to Kenya every year, and we have pushed him and encouraged him that we also want to be coming to Tanzania every year. And you guys are welcome to all our workshops. Our next workshop is in September, and you're all welcome. Nungu will always ask the details for our meetings, so feel free, and thank you. I'm going to give you an overview of the radiological evaluation of the knee joint. A clinical perspective. It is important for you as orthopedic surgeons, as you get along, to have your own perspective of whatever you do, clinical, surgical, and radiological. And physiotherapy was also raised. By the time you're a patient for physiotherapy, you should have made up your mind what you want that physiotherapy to do. You just don't write physiotherapy. So it's important that you have clinical perspectives of your practice. The knee joint is the largest synovial joint in the body. And because it's weight bearing, it's the most damaged joint in the lower extremities. And X-rays of the knee is the baseline of any knee pain patient. You should be able to do plain X-rays. And the plain X-rays, you should mainly aim for the three, that is AP, lateral, and skyline views, and also preferably they should be weight bearing, because when they are weight bearing, then you are able to assess the cartilage damage. So make your X-rays weight bearing, and don't do very short films. You want to X-ray and you want to X-ray the knee, there's no marker. You want to X-ray the knee, then you only X-ray the small part of the knee. You should try and have as a long film as possible. If you have a long film, then you're able to see more in your views. So that is critical. When you do your lateral view, for example, most people do it at around 45 degrees. But the important landmarks that you want to look for, and the most important in the lateral view, is you look at this line. This is the Blumenthal line. Blumenthal line for you as an orthopedic surgeon is important because At on the posterior part of the Blumen's line, that will mark your point where the ACL femoral insertion marker will be. So when you do your X-ray after ACL reconstruction, you expect your marker to be around here. If your marker is around here, then it means that you have the insertion is near anatomical. Apart from that, you want to appreciate that the condyles, the femoral condyles, try and make sure that the film puts them as symmetrical as possible. It's very difficult to achieve this, but appreciate when you see a lateral view and the condyles are not symmetrical, then appreciate that there's some asymmetry, and this will affect your interpretation of all the things you are seeing, the fibular head, and virtually everything, if it is not symmetrical. But if it is symmetrical, then the condyle normally will appear something like that. In relation to that also, if you have done an ACL reconstruction, I've said that it will be somewhere there, and that if you measure that angle, it should be around 49.3, or let's say 50 degrees. More on that also, these are standard intercondylar eminence. If it is a good lateral, intercondylar eminence will appear, the usual fibular head and that. At around 70 degrees, 70 degrees, if you've done a nice ACL reconstruction, then the marker should appear there at around 70 degrees. If you find that the marker is maybe somewhere there, then it's too vertical. If you find that it is like that, then it is too low. So it means that your femoral insertion site is low. So from your X-rays, you should be able to, after your ACL reconstruction, you should be able to look at the points where you have inserted your, it doesn't matter, even if it is soft tissue, you can be able to appreciate the tunnel. And with that, if you measure your angles, you'll be able to perfect yourself so that in the long run, in the sagittal plane, you're around 49, around 50 degrees, and in the coronal plane, you're around 73 degrees, like that. If you do your PACL, then on the opposite side also, that will be around 140, 90, 140 degrees. Correspondingly, I mean, contralateral. 70 degrees, the contralateral on this side should be around 140 degrees. Important also when you're doing your X-rays is to do the skyline views. So in orthopedics, those are our three standard views: AP, lateral, and the skyline view. Skyline view makes you appreciate the patellofemoral configuration, which has been discussed quite a lot. You should be able to just appreciate that there are angles which you can measure, like merchant's angle, but these become a bit complicated because it depends on how the X-ray has been taken. But roughly, you can appreciate this whether there's a tilt or there's a lateral subluxation, and there are angles in which you can be able to measure this, but they are not accurate because it depends on the way the film has been taken. So it is standardized. These angles, in my view, they really are not much use. All the angles, by the way, your patella alta, Baja, and so on, you cannot measure on any X-ray. If you measure any X-ray and you are given those angles and they are not standardized X-rays, those angles, they really do not mean much. So it's just to give you an idea of I've stressed considerations. You have to do long films, weight-bearing views. If you do weight-bearing views, appreciate the size of the cartilage space. In that, my marker is not working. in that this space can be divided into four. 0 is normal, and this is Lawrence-Kellgren classification. Lawrence-Kellgren classification is a group classification of knee of any arthritis. So have in your mind the width. If it is slightly reduced, maybe Kellgren 1, 2. If it is absolutely gone, then it's Kellgren 4. So with this, you should be able to plan your surgeries. As we get along, you'll see the importance of appreciating the severity of the arthritis. Because whatever you do will depend on this. Whether you're going to do a total knee, whether you're going to do an ACL, because if you have severe arthritis, Kellgren 4, and you do an ACL reconstruction, you're most likely going to damage the patient rather than help the patient. If you have a Kellgren 2 and you want to do a total knee replacement, then you are most probably going to overmanage the patient. These are patients who could benefit more from corrective osteotomies or some other type of management. This is the most important X-ray that you can take. It's in the majority of, when I talk about alignment, I'll talk again about this. But in the majority of places, it's not possible to do a film like this, a weight bearing. And I think it's only one hospital, not I think, but it's only one hospital I know in Kenya which is doing, that's the Aga Khan Hospital, which can do one film, which is like this. But in our situation, when we started, we are able to do multiple films. So we do a film of the upper femur up to the knee, wherever you get, and then the lower, and then you join the film to make a long film. And once you have a long film like this, then you are able to analyze the lower limb accurately in terms of getting the anatomical axis and the mechanical axis. I'll come into more detail about this, but this is an important thing we should be able to do. So the other one was in the coronal plane. You want to appreciate that your image has taken into consideration all the aspects of the frontal plane, sagittal plane, and axial plane. At least be able to appreciate that these are important planes. That's an example of the long film I was just showing you. And we'll be able to discuss this in more detail when we are discussing about alignment of the lower limb. That's an overview. But remember that there's also CT scans, and CT scans, they are more sensitive for fractures and avulsions. Avulsions, if you go to avulsions, are important in that if you get normally something here, small avulsion here, that is called the second fracture. Second fracture studies have shown that it's actually not, initial studies were saying that it's from the anterolateral ligament, but subsequent studies have shown that it is actually not. But it is related to a possible ACL ligament injury, but it's not an avulsion fracture of the ALL as such. But if you get any of these small avulsions here, then suspect your collateral ligaments, the lateral collateral or the medial collateral ligament. So avulsions are important. You want to evaluate them more using MRIs or CT scan. CT scan, when you are doing your bony assessment, CT scan is more accurate. And you can do your reconstruction with the CT. I'm only talking about the knee CT, but for like pelvis fractures, CT is mandatory. CT scan can also help you to appreciate femoral version. This is now becoming an interesting topic because some people say that when you have lateral patellofemoral syndrome, it means that it is a femoral torsion and not necessarily Therefore, in more advanced cases, you can be able to analyze the angles and be able to calculate your femoral version using the greater trochanter and the knee. Once you find that you've done a CT scan and the knee is not straight, like the knee is like that and not like that, then the femur is valid, and you can calculate if you have become more serious, you can calculate the angles fairly accurately with a CT scan. Apart from that, overview again, MRI is when you are dealing with soft tissues mainly, but the newer MRIs show more also bone. But when you are thinking more of soft tissue, then you should be talking of MRIs. In the MRI, routine MRI, the axials will help you with the retropatellar cartilage, and the coronal will the collateral ligaments. Collateral ligaments, you should be able to assess whether it is a partial or full tear and corroborate it with your clinical findings. If you find, for example, that you are doing a medial collateral stress test at 0 degrees and it is 0, then it is unlikely that you have a complete MCL tear. But if you are doing an MCL collateral at 0 and is positive, maybe 2-3 pluses, then that's good. But if it is light, then maybe it is just an ACL tear and a partial MCL tear. As you get along, these are the things you're able to do. In the sagittal, you evaluate your meniscus. And of course, the cruciate ligaments. Cartilage, you evaluate all of them. This is more of radiology, but at least appreciate your T1, T2 sequences. In T2 sequences, the cartilage and bone attack. And in T1, the fat is light, and fluid is also visible. So this is a T2, and we've said that the cartilage is dark, so that if you look at this one, I don't have a pointer, sorry. This is the meniscus, but if you look at that, you see that there's an interruption there. So this is a meniscus tear. This you should be able to diagnose. You don't need a radiologist to diagnose for you this. Then there's too much fluid in that area. Apart from that, posteriorly you would say that there's like some contusions, but the obvious thing there is the meniscus tear. Again, the meniscus tear there is very clear. Thank you. So as you get along, you should be able to read the basic findings of the MRI, not the details. At least identify your meniscus tear and the ACL tear. I don't have any there. Thank you. Any question?
Any question?
Any questions to Dr. Muhimbili on the presentation and the evaluation of the
So there's not a question to Chief. So then put your attention to next talk, which is the arthroscopic knee condopathology management.
Can we get help, please, where the presentation is sent? There's a folder which has the presentation. The girl doesn't know. Where's the gentleman who's doing IT? Where's the gentleman? There we go. There's two conditions that you will encounter related to chondro injuries. I don't know what TV is not watching. This behind me, I'm not focusing. There's two conditions you will have, usually the chronic situation of arthritis, and then there is the acute injury situation. Most of this talk is focusing on the acute injury related chondral damage. In the chronic situation, the treatment might be different. You mostly pain control and joint replacement or osteotomies, but in the acute situation, the aim is different, to try and regenerate the cartilage. Cartilage, remember, has no nerves and has no blood vessels, and the pain that somebody gets after acute cartilage injury is not really related to the cartilage itself, it's related to the bone under the cartilage. So when you tear cartilage, the bone under the cartilage is what suffers, what has nerves, and so by the time you're getting pain from a cartilage injury means whatever that injury has caused has reached the bone under. So there is pressure there, there is a fracture, compression fracture, there is edema. For some reason, there is pain coming from bone under the cartilage. The other thing to understand is that because cartilage doesn't have blood vessels, regeneration of cartilage is nearly, you can say, nearly impossible, because we can't get nutrients in there to although that theory is changing now, but generally it has poor regeneration abilities because it doesn't have blood vessels. It's mostly composed of water. If you look at the pie chart, I think somebody presented this in the last talk of IPCA, that cartilage generally has the organic, inorganic component, mostly water, and collagen fibers, collagen type 2, and protoglycans. They're called GAGs, glycose aminoglycans. And maybe because these protoglycans or GAGs is mainly keratin and chondroitin, and probably that's why people tell you that you can eat the chondroitin and keratin, and then you regenerate your cartilage. Outerbridge has classified, there is an international cartilage I think it's called ICS, or I forget. There's an international way to classify cartilage injury, but most people who do arthroscopy are familiar with the arthroscopy classification, which starts with the normal cartilage, then there's an abrasion, then there's fissuring that is less than 50%, fissuring reaching the subchondral bone and stuff, grading like that. It's good to be familiar with the arthroscopy classification when you're writing notes about whatever form of cartilage injury you have. The lesions happen usually when people jump in sports, or on treadmills, or when running away from dangers. Most of the time, a cartilage injury will give you a and on and off effusion. So the joint that is giving you an effusion on and off with pain after activity is usually more often than not having cartilage injury. We call it internal derangement, some kind of internal derangement. Could be meniscal injury, but most of the time in these young patients in their 20s, 30s, it will be some form of cartilage injury. And once, as we've said, once they start getting pain, then the bone under that cartilage is getting compressed. Activity-related pain, if the cartilage tears off and makes a flap, then it may catch. The flap sometimes can come in the way of the gliding motion, and then the patient feels like catching. Sometimes there's noise. The more noisy aspect of cartilage injury comes with the patellar chondromalacia, which is sometimes a chronic problem. And then for you to ascribe that pain to the cartilage damage, usually the pain should be located exactly where the cartilage damage is. So I need to emphasize this. If you do an MRI on a knee and it shows you some kind of chondral damage, there's edema subchondral somewhere in the anterior part of the knee, and when you flex the patient's knee and you press that region, there is no pain, then very likely that lesion you've seen is not the one causing pain. So cartilage damage that is causing symptoms in the knee in terms of pain must correlate with the pain where the location of the lesion is. The importance to underscore that point is you don't have to treat all of these lesions. Some of them come and go. Some of them, even if they persist, we don't know their natural history. And sometimes you can have a lot of patients you are treating for really what is not causing their pain, because we know that we are always wanting to treat pain. If you do an X-ray, if you're lucky sometimes and you're checking usually on the medial condyle, the lateral aspect, the lateral surface or the lateral region of the medial condyle is the commonest place involved in this chondral injury, the OCD. That's the first place you check. If you're lucky, you may see it like is demonstrated on this X-ray here, that lesion. It's not always possible to see it. You should have a low threshold. Once you've seen a normal X-ray, you should have a low threshold to doing an MRI for these needs. And as we said, for any knee pathologist, currently MRI of 1.5 Tesla and above. The more you go higher in the Tesla, 3 Tesla or something, I don't know. There are now a couple of hospitals, at least in Kenya, with these 3 Tesla machines. So the detail that you get with the MRI is quite spectacular. You'll usually be able to pick these lesions. And it's surprising, you may see it on the X-ray like this, but when you scope this knee, you may not see anything. Especially on the surface, you just find the cartilage is okay. So you need a probe to probe, and then you find the soft spot, and then we talk about the treatment. But emphasis here is on X-rays and then MRI to be able to pick this, and a good quality MRI should give you this. You should always get the various MRI, star, fat suppression, T2, T1. You should get all of them, and then the radiologist will be able to pick that there is chondral damage. In terms of treatment, sorry for that. In terms of treatment, there is a whole spectrum of. You look at this cartilage. Once you have determined there is cartilage injury and you want to treat it because it's confirmed it's the one causing the pain, then the treatments are variable. If it's just the beginning, the pain is not so much. There is quite a big room for non-operative treatment, control the pain, and in controlling the pain, we use normal non-steroidals and physiotherapy as pain is controlled. and then you can consider injections, the ones we talked about. So in this particular case, if you are using, if it is cartilage, consider almost like soft tissue, then you will want leukocyte-rich hyaluronic acid, but HA, hydroxyapatite, and PRP. Steroids are not good for cartilage. Injecting steroid inside the joint actually is chondro-destructive, so you will not be very wise because the patient has an effusion, you confirmed a chondral lesion and you're putting in a steroid. Of course, you seem to control the pain, but what you've done for the cartilage, you've softened it more, so it's not wise to use steroids. So the injections one would consider using here, HA and PRP. Please learn the PRP that you're using and check that you should use leukocyte-rich or leukocyte-poor PRP. It's in the literature. If it is fraying, like happens on the patella, and then coblation, there are some companies like Orthocare or something that have created. It's not the usual radio frequency. You know, the way we use RF to ablate tissues in, subacromial tissues and stuff. It's not the same technology. The coblation technology uses a different dosage of electric currents, and it creates some kind of plasma layer of tissue. And so what happens with this coblation technology, you bring the radio frequency close to the surface of the fraying cartilage, and it just shrinks onto the surface of the patella. So if you have this kind of fraying of the cartilage and you happen to be scoping, then you can bring in this kind of technology. Some of these companies with their newer radio frequency machines, you can change the mode on the machine, and then it gives you coblation. When it gives you coblation, then you bring it near the surface of the fraying, and all these things shrink, and you get a stable cartilage defect, so to speak. So you can use that, or if you don't have that kind of technology, you put in a shaver that is not very aggressive, and then you do debridement. When you're doing that, either coblation or shaving, we call that chondroplasty. So that is chondroplasty. Then you move to the next phase of the surgery, which involves, so that's debridement I've talked about. And when you're doing debridement, you debride to stable cartilage. Anything that is unstable is removed, you debride to stable cartilage. If in the course of that debridement you happen to get exposure of bone, then you want that bone to be bleeding nicely, and sometimes that exposed part, you can do a lot of things. You can put in, if it's a nice size, say 1 centimeter, you can put in oats, we'll talk about it, or you can microfracture. Especially microfracture is used if you're around in the trochlear surface of the femur. In the patella, it's debatable whether you can do microfracture. People can do microfracture, you can stitch Macy. We'll talk about the options that you have. In the tibia, it's not easy to do microfracture because we do not have attack. You don't have a direction you can attack nicely to do microfracture. Yes, you can have some chondro peaks that you can bend and put in the tibia, but usually the healing by microfracture is usually some fibrous tissue that later becomes bone. So because this is a very heavily, a surface that is taking a lot of weight, people, when you do microfracture on the tibia, patients end up being symptomatic anyway. It's not a very nice option, microfracture for the tibia. So microfracture will be usually in the trochlear surface. And then sometimes if you have a nice flap, and especially if this flap has some kind of bone behind it, then one of the options you can do is to lift off the flap, make an incision, and sometimes this has to be open procedure. After you've scoped, you've probed, you've seen how soft it is, it's large, this size, you map out that area, you open the joint, and then you make a cut in the cartilage, a clean cut, you lift off the flap, and then you clean the back of it, curate the bone under, subchondral bone, so that it is bleeding, then you reattach it. You reattach the same flap after you drill holes into this base. And this basically is, you are exciting bone marrow to come and heal that flap. And how do you reattach the flap back? You can use fibrin glue. You should have these companies that, like Arthrex or some Smith & Nephew, or I don't know if Double Medical they have. But you can also stitch. You can actually just stitch with If you bring it back, you are allowed to stitch several interrupted stitches of vicryl, and then you hold it. You rehabilitate the patient, as we'll talk about. So you can stitch back a defect, especially if the cartilage has some bone behind it. But if there is no bone behind it, then that cartilage will die. So you usually shave it off, and then you do either microfracture or a few of the options that I'm going to give you in a while. So that's microfracture. Again, microfracture, you debride the lesion to the edge that is stable, and then you use a chondropic. So in the past, a chondropic is a sharp awl, something, and it has a specific size and the depth measured on it. You mallet it in. People criticize that and say what you are doing is you are impacting bone. So you are creating the shoulders, and the bone around it is really impacted. So it's not good. So now they created a drill that is oscillating drill. Like some of these companies have an oscillating drill. So you put it on the machine, and then it has a drilling effect, and they say that is less, so you're not creating an impaction fracture. I don't think there is a lot of studies to, maybe just talk for business, because that drill is not cheap. They'll give you that drill, half the time it is disturbing you, it bends, it is not as stiff as a chondropic, and then they bill you 40,000 for using that thing which has failed. So before you start using these things, you also look at the cost to the patient. Microfracture is one of the biological methods of healing this. You will bring in mesenchymal cells from the bone marrow. There will be a blood clot here. The blood clot will transform into fibrous tissue, give you some stability and pain control. It does well for some time, but over time, the gains you've made, they deteriorate over a few years, and most of the time when you rescope this after maybe 5-7 years, you find it's really that fibrous tissue has become bone, so you are really on the path for arthritis. But it's one of the options, at least, to leave theater, and the patient will be painless for some time. They'll think you've done something. Other options are autologous chondrocyte implantation. Now, to do autologous chondrocyte implantation, you need a lot of money, you need time, patience. So what you do, you shave off some cartilage from, say, this areas that are non-articular on the edge, like in the notch area or on the outskirts of the joint. Then you dissolve this cartilage in some chemicals, you pick out the cells, you take them to Germany somewhere, they culture them, 6 months, they give you back a membrane. That membrane might be a fibrin membrane, or it might just be the cells in some vial. Then, so you now have this mesh that you stitch, you bring the mesh, you shape the mesh according to, so now you are rescoping now. So you come and clean this area up to bone, clean it completely to the calcified whatever layer, you remove it. And then when it is smooth, you stitch on the membrane, Now when it is clean like that, you stitch on the membrane, you shape the membrane, you cut what you need, you stitch with whatever monocril or vicryl, and then now you've created a space under there. Then you take the cells that have been cultured, you inject under there, and then you wait. And they have done studies that have shown, I'm telling you, this is a whole new, as you can imagine, is expensive surgery. It's a whole new field of this cartilage regenerating society of doctors that charge a lot of money. They are very rich. I don't know in terms of their experience and outcome. We are still discussing. The other option is, so that's AC, and the next option that you have, sometimes you've seen when we are debriding, you are shaving off a few slivers of cartilage. You see, you can go on the edge and deliberately shave off pieces of cartilage, but now the shaver is usually connected to a sucker machine. So how to be creative about it? There are specific filters created by industry, but you don't have to use them. You can use a gauze, like a Rytec gauze. You pull out the suction tube of the sucker tube, and you plug it with something like a Rytec gauze. Then you take it back to the suction machine, but in a sterile environment. Then you start shaving. You shave off cartilage from the edge of a non-articular place, and then the water will be passing as the cartilage is being trapped by the Rytec. And then you take out that Rytec, you empty the cartilage pieces that you've shaved, you mosselize them, so to speak. They've been mosselized by the shaver. And then you add biological material, PRP or mesenchymal cells, and then you put it in a membrane or something like Sagicel, but they are fibrin membranes. You stitch it back, and you have something like this. So after you've shaved you have picked the shaved cartilage, whatever's on your right leg, and then you arrange them in this area and you stitch it with a fibrin mesh. And after some time, especially this is a very useful for tibia. For tibia, you can get accurate if you have a contained defect, because you want that thing contained. And number two, tibia is at the best, so the chances of you losing the graft off is less. So you curate and create a clean surface, and then all these things, slivers of cartilage that you have shaved, you add in PRP or mesenchymal or adipose derived. You can suction from adipose, put in this, the whole of that broth. Some of these companies actually have a specific broth that has factors for growth of this cartilage, chondrocytes. Then you put a fibrin membrane, you stitch it, and you can see that after some years, there's an article there if you want, after some time, the cartilage has really integrated and giving a nice layer of cartilage. This is what I do with one of the patients. This is much like, now I've come back to the ground. What I'm talking about mostly is we don't have access to fibrin membranes. Maybe what you will get is Sagicel. And Sagicel, if you stitch it there after 2 days, maybe 3 days, it's gone even before you leave theatre. So it might not be very useful for us. Now this is useful for us. So there is, some of these companies will give you equipment called OTS equipment, autologous osteochondral transplants. So you have to read in the knee which parts you can harvest from, and mostly on the outer edge of the lateral condyle, you can punch out a few of those. So you assess the size of your lesion, you clean it, and There's a cursor there, that's the lesion. Partly this lesion was in the notch, it's not contained, it was not a very friendly lesion. If you are lucky, it will be in an area that is a bit contained, but this patient was having a lot of pain. So what we decided to do odds. So we make, you come with it's like, if you know a Jamshidi needle, it's the same concept, but now this is bigger, comes in various sizes. So you make a punch out after you clean the lesion, you make a punch out, you bring. So what I do is, what I bring out, I empty on the table, I don't throw it. Then I go on the outer edge of the condyle and punch out cartilage with the bone graft. When you twist it 360, it comes out with it. I punch this graft into the hole that I created, and now I pick this bone that I had removed and put it where this one came from. So it acts like there will be fibrous tissue, almost like you've done a microfracture there, but you don't have this hole looking at you. Then I go, you can have multiple sizes, depending on the size along the outer edge, and then in the end you have something like this. The beauty with this, they are usually very stable, you can manage them nicely, they get equal. It's artistic more than scientific. You do a nice job, you get a vein, and this one, in a few, it's like bone grafting. In a few days, this patient did very well. If you happen to be in a country that has allografts, you can, if it's a very big defect, more than 4 centimeters, you can hollow it out and put an allograft. But these ones are not good for younger patients. Allografts are not, their outcomes in younger patients is not very good. When you rehabilitate these patients, I think if you've done cartilage surgery, the cartilage goes through certain phases. In the early phase where it is very unstable, in the mid phase where it is partially stable, and in the last phase where it is completely stable. Almost like the cotton dow rubber analogy. Cotton phase, dow phase, and rubbery phase. So your rehabilitation should follow, respect those phases. When you are in the cotton phase, what you don't want is any shear forces or compression. So you can't tell the patient to load the knee, but you know that cartilage is nourished by motion. It is the motion that gives the fluid, and the fluid gives diffusion. So if you don't move, it will not heal. So you give unloaded motion without compression, so that you're not getting shear. That is the cotton phase. And then in the dough phase, where it is a bit semi-partial stability, then you start focusing on function. So that motion is not only motion, it's full range of motion without physiologically loading, because you can't have compression. So you graduate this patient, say every 6 weeks, from motion to full range of motion to loaded motion. And this is like respecting the cotton dough rubber analogy. And then also you need to know what have you done. If you've done microfracture, most of the time you can rehabilitate faster. But if you've done MESI or AC, then rehabilitation is a bit slow, even 6 months, even sometimes 1 year. It is slowest when you've done AC. Thank you very much.
So thank you so much for coming, because I think everyone of us, I think at some point we've encountered these cap lesions, and it's really a very good talk, and I think I expect some questions.
You told me what is the lifespan of autologous chondrocyte? Because as far as I know, it's not very much. It's almost like microfracture. All these techniques, do you have any one which has very good long-term results? Long-term. I will not do any.
I think that the topic of autologous chondrocyte transfer is still is almost like the biologics story. I knew only one guy where I training who was doing this, and he used to be flying in. If you notice, most people keep off from this because you can't give guarantee. But this one guy used to fly from Munich, Frankfurt, Zurich. He's one guy. He was the cartilage expert, and he used to, he cultures. Like this month, he flies in with his cultures that he did 6 months ago. I think that currently, if you search online, we are now getting information about the outcomes of this, because it's not a very old profession, this one. But with improvement of MRIs to 3 Tesla, now we can be able to talk conclusively whether these methods are working or not. And as you've seen there, I've posted a few of the MRIs that show that actually cartilage can be regenerated. In terms of, but you see now, we also need functional outcomes, not just MRI outcomes. So matching radiological with the functional outcomes, not much has been done. And it's one of those things, even if you have registrars who are interested in studying, they can study. I'm just cautious not to dismiss it, but I'm not sure that it's something I can, because also it requires a lot of skill. For me, I think I have about 5-7 years of experience doing OTS with really good patients, about 5 or so patients, not many. Almost all of them, usually they're younger, doing fine, as in the symptom-wise. But I haven't done a rescope to see if the cartilage was lined with urine. But symptom-wise, at least the odds, I think, is the best.
Thank you. Any question on this topic?
Thank you, Dr. Tony. You talk about not fighting against nature. And now, when you talk, this is a question of degeneration of the joint. First of all, I'd like to talk a bit of the sequence of the use of antibiotics, including steroid. Because with the steroid, you see that it's just on some sort of has a limited time of symptom-free. But as you say, you started with the NSAIDs, you go to to let's say rescue supplements, then steroid. Is that the sequence you'd like to go to propose to the young people to understand, or what is the sequence of pain management or symptom management when it comes to the pain and fungal lesions. That's one. And secondly, when you talk, for example, the cases you talked, in the weight-bearing areas with microfracture, you talked about where there is less pressure and where there is less pressure. The area where you have done your X, which part of the joint where you can do microfracture and the X, which you have done?
This is how I look at it. So cartilage damage, the degenerative one, where it's not a trauma to a spot, one spot. So what we discussed here is repairing a traumatized focal cartilage lesion. But when you have degenerative cartilage lesions, like will happen from Malaysia or arthritis, basically fraying and then cartilage erosions, the treatment is frustrating. Mostly it's a progressive disease, but one can do lifestyle modification. You can do NSAIDs and physiotherapy in the beginning, yeah. And then if you have, say, grade 2, 3, you haven't decided, maybe 3 is a bit, but those grade 2s that you're thinking you don't want to replace. Maybe you are waiting for grade 3, 4 before you replace. And this is a patient who doesn't have a focal lesion and has come with acute symptoms that you cannot control with NSAIDs, rest, lifestyle. You can't control with all those. Then there is probably room for you to treat in a very controlled way. And I tend to find, I don't know what my colleagues say, I tend to find that steroids are more useful in the weeping joint, a fusive joint rather than a dry joint. In most of the times when I put a steroid in a joint that is dry, I less and less use steroids anyway. But if at all I'll put a steroid, I think the outcome is far much poorer in a joint that is dry than a joint that had an effusion. So I think when you will be putting a steroid in your mind, you're thinking you want to control some kind of inflammation. And what is the quintessential sign of inflammation? Is some kind of swelling, edema. So if a joint is dry, then I don't see how steroid is helping. But then there is some role for steroid there too, if the NSAIDs are not working. As you progress, but you can't be doing it every week. Then of course you'll do it maybe once or twice a year. And anyway, you think about another thing as you have investigated the joint. Then you can progress to probably towards surgery. But for focal lesions is where now all these things come in. So in that pathway of maybe before you even do steroids, maybe it makes sense if you have an orthobiologist colleague, because not all of us believe in this thing. But maybe that's a patient you can try HA injections, but you discuss with the patient that we are frustrated with this condition at this stage, we don't have a lot of we can do PRP. Please check that the type of PRP inject, because now the people doing it are saying that it's not just any PRP. And also they are saying even in the knee, use an ultrasound so that all of it is going properly, not going in the fat. A lot of those things, if you observe them, maybe you'll have been HA, hyaluronic acid or PRP. You can mix them. And then now go to steroid and go to replacement. But for focal lesions, then you go to this kind of stuff. The second question was about?
Microfracture.
Oh yeah. So microfracture, you see, when you microfracture, you stimulate bone marrow cells to come into that place with the blood clot. You're thinking mesenchymal cells, and you're hoping they can differentiate into cartilage forming cells, which usually doesn't happen. The people who do the biology think that if you make motion over mesenchymal cells, they think this is a gliding, whatever, sensation, so they make cartilage. But if you compress them, they make fiber and then they make bone. So in essence, if you do microfracture in a region of bone that undergoes pressurization, which is frequently most of the parts of the knee, you end up with bone. And if you follow up microfractured regions after a few years, 5-7 years, if you probe it, it's bone. It's just that that bone is limited maybe a little bit below the main surface of the cartilage, and that's why the patient might be feeling that void, because that bone formed that layer, it protected the subchondral bone, which is the one that had nerves. So the pain has gone. So in terms of pain management, you won the battle for some time. Ultimately, you just get progressive degeneration. So what it means is that in the gliding areas, like in the notch, and these are areas you can access very well, you can do microfracture. On the patella, people do microfracture. It's very, I don't know if you have ever tried to do microfracture on the patella. It's most difficult, unless, especially arthroscopic, unless you open it. It is very, very difficult. Even holding that thing down so that you can microfracture it is really very difficult. And when you get this oscillating thing, it is half the time sliding off. It's really very frustrating. But people have done odds on the patella. They put this thing, all arthroscopy, there's videos on this, how to do odds on the, if it's a focal lesion on the patella, you can either do it open, do odds and implant, or you can even do it arthroscopic, and it is very possible. They deliver it with sutures. They make a big drill hole through the patella, just the way you deliver a graft, let's say ACL, into the joint. They pass those sutures by arthroscopy into this big hole in the patella, and the bone comes with its cartilage and stamped into place. A lot of these things, the surgeon is happy, his pocket is happy. The follow-up is what is still a point of discussion. But for the patella, is the most frustrating. Most of the time, you end up with chondroplasty, or if you can, microfracture, or if you are thinking to put odds, like in my hospital, you can do odds, but ultimately the degeneration will continue.
So here in our center, of course, we've done some patients that we found they are playing, but most of the people done the fractures of PRP. And some of them that they are in coma, they are playing. So what do you advise? The young patient, football player, stop, the cartilage, what should you advise as a doctor?
Hopefully you have done good images, you have done good MRI, there's no focal cartilage injury. If there's no focal cartilage injury, it's generalized chondromalacia. There is quite some good evidence that use of orthobiologics, the return to sports is quite high. We use this PRP and HA injections after some time of rest and rehabilitation, the return to sports. But I think it's important to give them more time and a little bit for the cartilage to heal. A few of them, if you've done good investigations, will bring bone edema, and there is role for management of the bone edema as we are still discussing this matter of bone edema. Coming up with one of the things you may need to manage, either by drilling or by using bisphosphonates. You can give bisphosphonates to manage the bone edema, you can inject PRPs, or you can just drill it. And I will mention one of the areas where if the cartilage is get focal damage, you can actually drill it without having to lift it off the way I explained. So one of the things you can do if you pick that, it's OCD lesion, you can put in an thin wire from the joint, let's say a 2 millimeter, around 6 millimeter wire outside, then you use a cannulated drill bit, you measure the depth, you drill back on that wire, so that you have, then you change the direction again, you drill on that wire, then you are drilling at that area. Or you can just use multiple operations with KY. Or if you are very adept, you can observe the lesion and drill from outside. Either way, you're just drilling. In terms of managing these young patients who are sports people, rest and recuperation almost always with NSAs will help with physio and rehab. And then you can follow with orthobiologics. And then if you do a good investigation, if there is a focal lesion, then you address the focal lesion as it is.
Chondromalacia patella in a young patient, it's better to leave the patient alone. Or you give hyaluronic acid works. But microfracture in the patella, the results are not. So microfracture in the patella be ready for problems, especially in sports days. So normally you give hyaluronic acid, repeat it 6 monthly to 12 monthly. PRP is a very, very difficult situation because number one, like we talking about saying, is it leukocyte rich? Is it leukocyte poor? And how many injections are you going to give? These are still questions which are not answered. But at least hyaluronic acid you can give once and then you take time and repeat. But PRP, even if you, how often are you going to give the PRP? And in a chronic situation, the patient has been having a convolution potential. You give PRP, how is it going to help? This is the big question which is there. But the latest study which I have reference here, they have said PRP in the long term helps. But there are those issues. How often?
For these sports people, just to sorry, please take time and examine the knee very, very well. Half the time I've seen, especially, like people our age, maybe your age, when they start exercising, because they have suddenly realized I have a tummy, I want to go and, burn the tummy, and then they come with anterior knee pain. It is frequently. Yeah, you will see chondromalacia everywhere, but it's not the one causing pain. You know what they have sinding last? You know this funny tendon. If you examine this knee, you will find things outside of what the MRI is telling you. Like you will not pick sinding lassen by MRI. So you just examine, you find it is the patella tenderness there, or it is the quadriceps tendonitis, or it is one of those sprained ligaments, and then you rest on some gels or at most an injection of steroid there. You find he has pinched the Hoffa's part. But now because you've done an MRI, the only thing they are seeing is chondromalacia. You think it's chondromalacia that is really causing the pain, when it is usually quite frequently pesan serine bursitis, sinding lassen, and stuff like that. Okay.
I think this was a very good talk, and so again, let's take it before we go for lunch. Let's have our session to Dr. Winga for another talk, alignment, which is a very good talk. Go for then,
I think this is one of the most important and upcoming topics in sports medicine. Historically, I will not go much with history, but you can go through this at your own time. That by 460 BC, the concept of alignment was already being fed. In that, when there was malalignment of the lower limb, bent lower limbs, motion was impeded, and that this could be improved by trying to straighten the leg. So in the early days of osteotomy, it was mainly to correct deformity, to relieve pain, and improve function. But there were some serious setbacks, and lack of correction and stiffness were important, but this still remain a problem to date. So modern osteotomies were made in the 1900s. And the first 1934, Brett did an osteotomy for recavator. You appreciate that recavator makes motion difficult because the knee sucks posteriorly. And most serious improvement came in 1958 when Jackson did the supracondylar femorocondylar osteotomy for valgus deformity, high tibial osteotomy. The advent of proper osteotomy as we know today is by Werner Muller in 1969, when the AO plates became standardized, and from then on, a lot has taken place. Another significant point is Fujisawa. Fujisawa in 1979 was able to plot the what's so-called Fujisawa points, which is around 62.6, about 62.9%. At which point, if you do the corrective osteotomy, but I'll show you those alignments, then you achieve a good alignment. Nothing to say about that. So come to this. This is the most important image for you today when we talk about alignment. It is important to appreciate that in the normal axis, which is from the middle of the femur head, there's a way you calculate this. If you take 2 points on the femur head, draw a line, and then another 2 points and draw a line. The middle of that is the center of the femur head. And from there onwards, you draw a line, straight line, to the middle layer of the tip of the midline. That gives you the mechanical axis. The mechanical axis deviation will be measure for you how much alignment that you have. In the normal situation, it will pass through the middle of the knee, around there. And that's a normal mechanical axis deviation. So if you draw a line from the femur head to the straight line, that's your normal mechanical axis. If the deviation is towards the medial side, then we are talking of medial malalignment. Example, Geniveras is an example of medial malalignment, the most common medial malalignment. If that axis deviation goes out from the midline, then we are talking of lateral mechanical axis deviation. And those are the only parameters which will guide you on how to do your correction. So first you must get your mechanical axis deviation to be able to know is the leg aligned or not. If it passes through the middle, then there is no malalignment, even if the leg looks bent. If there's an alignment, it is at another point of the body, maybe in the hips, in the scoliosis, or so on and so forth, but not in the lower limb. But it could be malalignment in the spine, for example. Anatomical axis is different. In the anatomical axis, you draw a line in the middle of the femur and also in the middle of the tibia. You cannot correct alignment alignment of the lower limbs with an anatomical axis deviation. Anatomical axis deviation just helps you to appreciate roughly how to move. But you cannot correct your alignment with an anatomical axis deviation. So once you have done that, and you go to mechanical axis deviation, your most important parameters are two. There's a mechanical axis lateral deviation, which is that angle. This is around 87 degrees plus minus 3. If it is more than 90, over 90, the mechanical lateral axis deviation, MLDFA, then you have a valgus deformity. So this will be important for you to, when you are doing your correction, because at what level do you correct? Do you correct in the femur? Do you correct in the tibia? So by measuring these two, once you have got your mechanical axis deviation, you want to know whether the deformity is in the femur or the tibia. And this is how you find out. By measuring the mechanical lateral distal angle and the mechanical axis medial proximal tibial angle, those two angles. Those ones will help you know where will pinpoint to you where that deformity is and where you correct it. Before you get any of these two, you cannot correct. It's impossible. If during correction, the joint angle, joint line is deviated, then it is unlikely to correct with one operation. That patient will need a double osteotomy. So get me on that. If your joint line is oblique, then that patient will have deformities in two planes, the femur and the tibia. At whatever level, you find out by measuring these angles. The angles which are if the point line is straight and you measure the angle, then from there you learn how to correct the femur or the tibia. The majority of the time in the Vegas, the deformity will be there in the clinical lateral axis deviation. So it will be a superior femur osteotomy. If it is a mechanical proximal tibial angle, which is diminished, then most probably this will be a varus deformity, and the correction is in the tibia. As you start your long films, I mentioned to you earlier on during radiology, do not do short films of the knee like this. You know, if you do a long film, even before you do your full weight, you'll be able to appreciate, is this patient in varus or in valgus? Like in this patient, you can see immediately that weight bearing a fairly long film, there's varus there already. So this is a patient with varus on this knee, the left knee, the right knee is normal. So once you pick that, then you continue with your long film. Long film, like I said earlier on, if you cannot take a complete long film, you can take multiple films and join them. They are still very fairly accurate. In this patient, if you follow this line here, it passes medial. If you follow this line here, like that, you see that it passes medial. I don't have a good point, but that is it. And when it passes medial, then it's a varus deformity. It's the same patient toward this. So you do a T-corrective osteotomy. If you are doing a T-corrective osteotomy, in the types of osteotomy, there are two types of osteotomy. You can either do an open wedge, this is an open wedge osteotomy, or you can do a closed wedge. In the open wedge, you make your cut around there, then you open up without breaking the lateral cortex. If the lateral cortex breaks, then not a problem. Just put another plate to support it. So that you have two plates. There's no problem about that. If you're doing a closed wedge, I hope I have some photos of closed wedge. Then you do your osteotomy from the lateral side. The results of closed wedge are very good, but the problem of closed wedge is there's a tendency to lose correction over the years. But the results are good. And initially it was I used to do very many with my mentor, and the results were very good. But over the years, you may lose correction earlier. Another important point is that when you're doing osteotomy, remember your lateral view, your sagittal view. Don't just concentrate on the valgus and varus. You must make sure that you control your sagittal view on the film. If you leave your sagittal plane to alter, then it also affects the biomechanics of the ACL and PCL. If you increase your vertical slope, you know very well, by more than 15 degrees, then your ACL becomes unstable. So remember that. There's another example. If you measure this one also, the line was passing, this is a patient about 65 years old or something. The line was passing laterally. The mechanical axis deviation was passing laterally, and the lateral distal femoral arm was also increased. Lateral is okay. The plane of the lateral is okay. In this case, he managed by a medial supracondylar osteotomy. This is a closed osteotomy. So in the femur, majority of the osteotomies for valgus will be closed osteotomies, and this is a sentence plate specifically for doing supracondylar femoral osteotomies. And osteotomies you tend to do when you have unicompartmental arthritis. So in the management of unicompartmental arthritis, especially in the younger patients, or patients with meniscal lesions, medial meniscal lesions and so on, you have to be able to do osteotomies. Otherwise your results will not be good. If you just do your ACL in a varus knee and the posterior slope of more than 15 degrees and you've done your ACL reconstruction or you've done a meniscus repair, it will not work. So you have to correct your alignments also with the femur, both coronal and sagittal. Again, lateral control. This is another example. This is an example of a very old patient. When you did our first X-ray, before you do your film, you can see that there's valgus. Just by looking, we call it what? Eyeballing. There's a valgus deformity on this knee. So lateral is good. So you do your long film. When you do your long film, in several cases you can even just appreciate without doing mechanical axis deviation. If you follow me from here, then you just follow a straight line. Oh God, to here, you see that the line is lateral. If you follow a line from there, a straight line to here, you'll appreciate that the line is lateral. So this mechanical axis deviation is lateral from the hip line. And immediately you conclude that it is a valgus deformity. So what do you want to correct for valgus deformity? We have done a mechanical axis deviation. So the same line, mechanical axis deviation, if you put your mechanical axis from there to the joint line, then you draw a line. Then you measure your mechanical lateral axis angle, deviation angle, distal angle, and it's 7.7, the measurement I gave you, and you find that this is less or more, and then you know where to correct. So with bigger deformities, it's much easier. Even without body, you can just know that this is definitely a valgus. In this patient, this is the patient with valgus. Again, you corrected the supracondylar femur osteotomy. These angle plates were the older symptoms plates. They are not good for this now, but they are very good for. This was an intertrochanteric stainless steel symptoms plate, and they are very good for correcting angular deformity. So again, you've done visualization, supracondylar osteotomy, and the knee is straight. This patient now is about 5 years post osteotomy. That joint line, the joint line, once it is restored, the cartilage becomes good, and the subsequent X-rays show that there's complete restoration of that joint line. If it is unicondylar arthritis, this is an example of what I was telling you, that in your early days like now, you do multiple films. When you have done your multiple films, then you do your, from that earlier image of axis, you draw your angles. And they're fairly accurate. In this situation, we are able to pick that even that stop needed correction. This is an example of closed wedge tibial osteotomy using a T-plate. This is an old method. This was before the advent of locking plates, but it still worked. So you can do a closed wedge osteotomy, and this is the other knee. If you look at that knee and that one, you can see that the joint space is improved. Another example of the older methods which you can use, you just do a multiple X-rays. As long as they are done from the same distance, it means the magnification is the same, then you can join the films up. When you join the films up, remember the sagittal plane. When you correct the coronal plane, it's easier to tilt the top fragment so that you get your sagittal plane to be at least 0 to 11 degrees. 0 to 11 degrees. A posterior tibial slope of more than 15 degrees is bad. The same patient, you see that after correction, if you look at the tibia, the sagittal, the tibia is, the sagittal plane is also corrected. So it's multiplanar correction. And the closed wedge osteotomy. This is an example of when this patient also had severe patellofemoral arthritis. When there's too much lateral translation of the patella, especially with arthritis, even minor than this, it's better to do an osteotomy. And this is the standard osteotomy for this is Ferguson's osteotomy. Anterior medial translation of the tibial tumor. When you're doing the tibial osteotomy, you slant the tibial tubercle osteotomy depending on how much you want to translate medially. If it is you do an acute osteotomy, when you turn the patella like this, you'll be able to achieve more anterior translation and medialization. Basically, this is an overview of the osteotomies of
Thank you, Dr. Owinga. Any questions for Dr. Owinga?
Yeah, that's HTO is quite a difficult topic to cover. It's well done. So, what's your advice on recurvator, the types of osteotomy for recurvator?
To be sagittal osteotomy, in that if you look at the angles, if you look at the angles we are talking about, in the standard measurements of the angle, the sagittal angles, and when you do your long film, you'll be able to see that when you're like that, the correction most probably normally will be in the tibia, but it may be in the femur. I cannot be sure about that. But you have to first measure. Then, where it is excess or reduced, depending on the standard, you'll be able to correct it. You can correct any deformity. Recurvatum, hyper, by measuring the angles. It's just like the tibial slope. If you have a tibial slope, posterior tibial slope, you do a closed anterior sagittal wedge osteotomy, and you correct the anterior slope. So if you have a recurvatum and the tibia is reversed, the tibia is like this reversed, the posterior, the opposite of posterior slope,
then it gives you a severe recavator. If you do an open edge of that, you should be able to achieve your realignment. But your most important thing I want to tell you is yeah, yes, I've seen. No, it's yeah. There's a lateral. There's a lateral one. In this lateral one, you look for the medial mechanical proximal tibial angle, and no, sorry, that's my fault. There's no lateral here, but there's a sagittal of the same. There's a sagittal of this in the books, in the literature and everywhere. There's a sagittal of this angle, and in the sagittals, you get the same mechanical lateral distal femoral angle and then mechanical proximal medial tibial angle, and the ankle and the ankle joint. Then, if it is the hip also, there are measurements for the hip. There are standard measurements for the hip. So I think that answers the question. For recavator, most probably it will end up being an open wedge osteotomy. Otherwise, if you do a closed wedge, you will reduce the height of the tibia and cause a patellar bulge. Any other question? So sorry, there's a lateral of this. It's not here, but it's available.
When doing lateral closing wedge of the tibia, are there times you address the fibula as well?
Yeah, that's important. That's very important. If you're doing a lateral wedge osteotomy, you must do a fibular osteotomy. It's mandatory. If you don't do a fibular osteotomy, then there will be risk of non-union, and also it causes pain at the fibular head. And that is also the advantage of open wedge osteotomy. If you're doing an open wedge tibial osteotomy, then you don't do the fibula. You leave the fibula intact. The fibula is not affected. And one of the reasons why people went more to open wedge was because of that. You don't have to address the fibula. But in closed wedge, you must address the fibula. Otherwise, it will go into non-union. That's a good point. This is an overview, so we can't discuss everything. There are many other issues. There's the issue of retracting the nerve, the neuropraxias, and all those things. Another question?
Finance suggestion, I just wanted to know if there is any, with regard to the two different types of osteotomy, which is open wedge and the closed wedge. Is there any implication in terms of leg length? Which one is more prone to changing leg length?
Okay. Apparently, there's not much difference. Even if you do a closed wedge, the difference might be 0.5 millimeters. Even if you measure all these guys here, you'll find that leg discrepancy of about 5 millimeters or so is fairly common, and it doesn't cause any change in gait. But in principle, if you have to do a double osteotomy, then your leg length is important. If you do both closed wedge osteotomy, then you lose more. If you do only one, open wedge length is good because you're increasing the length. But it doesn't increase the length by, these are things increasing the length by maximum of 10 millimeters. If you do osteotomies also which are more than 10 millimeters, then be careful. The results might not work unless you are doing a bone graft or something like that. These alignments are normally between up to 10. The mechanical effects of normal gait is up to 10. Any osteotomy is bigger than that, you will do a double osteotomy. Otherwise, the results will not be very good.
Doc, thank you so much for the lecture. But two questions. The first one is what's the role of, if any, what's the role of preoperative arthroscopy to look at the compartments to see where you're going to direct the mechanical axis? Is there a role at all preoperatively? And then the second question is about DOM osteotomies. Is there a role for that? And what's your experience in doing DOM as opposed to opening or closing osteotomy? Thank you.
Okay, those are good points. All the patients will do arthroscopy first. Arthroscopy because especially in medial degenerative patients who have medial meniscus tear, medial meniscus degeneration, and you also do your arthroscopy to make sure that your contralateral compartment is good. In that, if you find that you are going to do, where you are going to put your weight, there is arthritis also, then the results might not be very good. You might have to change the technique. But we find that by good neurological and MRI evaluation, even in old patients, when you go in, you find that it is unicompartmental. Even at 70 years of age, if you make a good neurological evaluation, you find it's unicompartmental. But arthroscopy is important. To address the meniscus issues and issues of cartilage, you may have to do microfractures, so on and so forth. The other issue you mentioned is the dome. The dome, personally, I don't do dome, but dome as a whole, when you are dealing with malrotations and so on, and these are mainly guys who do Elizarov sort of techniques. There are a lot of osteotomy when it comes to Elizarov. Those ones you are trying to manipulate many rotations and so on, then you can consider them. But we find that in our normal malalignment of varus valgus and recurvatum and posterior slope, these ones are normally sufficient. But arthroscopy is a must, actually. A must.
Thank you so much for that talk. I have a number of questions, maybe 3 questions really. Number one, what is your technique of doing the osteotomy? Do you use an oscillating saw through? Do you use an oscillating saw up to one point and then switch to the osteotome, or can you sometimes do it with an osteotome alone? And then also, is your osteotomy always complete, or do you sometimes leave it incomplete? Especially you doing the wedge osteotomy. And then 2, how do you, when doing the surgery, how do you measure your angle of correction? Do you just pretty much eyeball it off your x-rays, or is it accurate? And if it is accurate, how do you translate degree of correction to the height of the wedge that you're going to take out when you're doing the surgery? And then the third question is, in an elderly patient with malalignment and say with compartmental OA, like the last case that you showed us, what are your options? What are your options? I mean, I know you have like a number of options, but would you choose corrective osteotomy over unicompartmental replacement, or would you even sometimes consider a total replacement in that situation?
Okay. Let's start with number one. When you're doing an osteotomy, when you're measured, in the early days, when you're measured your mechanical axis deviation, then there's what is called the Fujisawa point. Fujisawa point is the ideal point of the osteotomy. And if you put that line on in the initial days, if you draw from that mechanic, the Fujisawa point is around 62 point something, 62 percent of something of this line, the joint line. So once you go to a Fujisawa point, you put a point there. You will draw your mechanical axis deviation now, corrected mechanical axis deviation. From that femoral head, you pass through the Fujisawa point, going downwards. And that angle on top, from the normal mechanical axis deviation with the new mechanical deviation from the Fujisawa point, that will be your angle of correction. And that angle of correction, you'll be able to translate it to this level. In this level, if you're doing an open wedge, it's simple because you want to aim at the fibular head with one cut, but you do not go through. If you go through and you're doing an open wedge, it's a disaster. You must put an electroplate. That's important. If you do an open wedge osteotomy and it goes through to a complete, you must stabilize the opposite side, otherwise it will fail. In a closed wedge, you may get away with it because you compress. So in closed wedge, I normally will not bind very much. I will just compress with that plate. But in an open wedge, you cannot afford to go through. If you go through, the operation has failed. It means you have to put a plate. So you aim for you go about 2/3. Then 1/3, when you're about 1/3, to hit the fibula, you open it up. It works out well, but in osteoporosis, it may give way and give through. So that is your first question. The one of Fujisawa point is also important. You check in the literature Fujisawa point. Once you get to Fujisawa point, then your joint line is straight. You are able to measure this normal joint line with that Fujisawa point. Then it will give you your new mechanical axis deviation. And that is where you aim to control. But like I've said, the majority of times it's around 8-10 degrees there. It's unlikely that you get this. If it's less than 3 degrees, please leave that patient alone. Unless he's having arthritic changes or he's having meniscal degeneration. There's a room for doing high tibial osteotomy to help preserve the meniscus. So if the alignment is not significant, there's no evidence of arthritis, the joint lines are good, then there's no indication for you ask another question. Yeah, in the elderly, I believe in osteotomy more than total knee, and it's there in the literature. If you check in the European literature, for athletes, these old joggers, people jog cross country and so on and so forth, with unicompartmental arthritis, they have better results. Number two is your knee. So to me, it's better to do rather than do a total knee, which is going to get infected. After that, it's going to fail. The revision rates are high. If it is your own knee and you do it in compartmental and succeed, to me, it is better. But that is a matter of choice. It's really a matter of choice. But if it were me, I'd advise that you do in compartmental, you do osteotomy. Number two is the role of unicondylar arthroplasty. Unicondylar arthroplasty is different from this, in that in unicondylar arthroplasty, the mechanical axis deviation is normal, but the patient has got arthritis. So that's the definition of unicompartmental arthritis, but with a normal mechanical axis deviation. In those patients, you can do a unicondylar arthroplasty. Same thing with about arthroplasty. Results show that half of them, almost all of them, eventually go to total knee arthroplasty. later on maybe when it is fully refined, it may be a specialty on its own. People, I don't find any value for it because they are knee arthroplasty. Another question? Yes, sir.
Thank you. From my experience, especially in the skeletal mature patients, one of the complications of multiple osteotomy, they end up with the recovered tongue. And I would like to hear from you, how do you mitigate that when you're doing your osteotomy at the bottom tibia? The second question is about the need to apply Cancella's bone graft. What is your experience in terms of the two population, the pediatric and the skeletal mature patients? Do you do routine grafts application when you do open major surgery? In which population do you do? Do you do any pediatrics or do you do any skeletal mature patients?
Number one, we don't graft. All open wages tutoring don't graft. Unless it's anything bigger than 10 millimeters. Like I did another patient recently, we were correcting for height. Old trauma in the tibial shaft, and you had to do a very large to correct for height. So that one, because of lengthening, we grafted because there's a lot of colors there. But in a normal osteotomy around that, there's no need for graft. No problem with osteotomy. And that is why we are saying you make sure that you don't go through the bone. If you don't go through the bone, normally there's no need. If it is stable, we find that there's no need for bone graft. We don't bone graft. And the results are good. In children, you raise a very good point. At what point do you consider doing an osteotomy? Remember that children are growing, and that as they grow, the osteotomy corrects, the venous of valgus corrects itself. Therefore, these are not operations we do. We want to do these operations when growth has stopped or is about to stop. If you have a child who has very, very severe valgus or villus, you could consider uni-epiphyseal stepling. Then you monitor. But if you do an osteotomy in a kid, if you believe me, the results are disastrous. Because it will accelerate growth of that side you have done, the deformity will increase, and then you get those things wrong about. You are talking about cavatum, we are talking of those funny types of deformities which come because of asymmetry of growth. So you want to keep your children to continue with symmetrical growth. If you're going to correct it later. But majority of villus or valgus kids, they correct by the time of maturity. I hope I've answered your question. So stapling, you could do unilateral stapling.
Thank you very much. We were hoping to save some time. I think this topic of HCO has elicited quite some discussion. Thank you very much. We are happy that we included it in the curriculum. Now you have a armamentarium in your pocket. Put HTO as one of the weapons you have for cartilage damage. Okay, we have to go for lunch. It's 1:30, and we were hoping the presentation of patellar instability. I think we'll have it after lunch. We cannot go up to 2 p.m. We will riot. Gen Z will riot. So let's have lunch, please. So we meet after lunch.
Summarize the presentation. So we will go through the anatomy, the pathological anatomy, and the presentation of patellar dislocations and the treatment of patellar dislocation. Now we go through the anatomy. I will discuss an anatomy of the movement of the knee and patella. As we know, the patella is on the anterior part of the knee, and when it moves throughout the range of motion of the knee, from extension all the way to flexion, it starts on the flat surface of the femur, and it moves about 9 centimeters as you flex the knee. At 0 degree of extension to around 20 degrees, the patella moves from the flat surface of the femur all the way to the entry of the trochlear fossa. And from 30 degrees to 60, it is in the trochlear fossa, and beyond 60, it is still in the trochlear fossa. So when it is in the knee is in extension, the patella is up there on the flatness of the femur, and as you extend, as you flex the knee, it goes and engages on the trochlea. So in extension, it is stabilized by soft tissues, mainly the medial patellofemoral ligament. And when the dislocation occurs in extension, it is usually due to insufficiency of patellofemoral ligament or injury to the patellofemoral ligament. This structure are supposed to guide the patella to the trochlea, to the entrance of trochlea. When the dislocations occur at around 30 degrees, usually it's bone malformation in conjunction with the MPFL. So at 60 degrees, it's in the trochlea and all the way to the full extension. Now, what are the causes of patellar instability? The first is MPFL instability or insufficient. As I said, in this case, the dislocations occur in extension and up to around 20 or 30 degrees of flexion. Usually it's due to injury and due to other causes. Suppose we have other issues which cause this dislocation, the MPFL will become relaxed, and as a result, you will have insufficiency of MPFL. This is an MRI scan of the patient. This is at 0 degrees. This is at around 30 degrees. As you can see, at 0 degree, the patella is aligned on the flatness of the femur, on the anterior part of the femur. So soft tissue MFL has to guide the patella at exactly that position when you are flexing. And this is at 20 degrees. It's at the entry of the trochlea. So even at this point, the soft tissues has to guide the patella. Now, if dislocations occur in these positions, it is not because of bone malformation, it is because of injury to the MPFL or insufficiency of MPFL. This again a diagrammatic presentation of the MPFL tear. Here the MPFL is torn, so when you flex the knee, the lateral structures pull the patella laterally, and it dislocates even before it enters the trochlear fossa. Again, this picture shows insufficiency of the MPFL. It is not torn, but because of repeated dislocation, it becomes stretched and it becomes weak, and dislocations occur. Another cause of dislocation is highlighting patella alta. If in this case the patella is very high, and when you flex, it is still high and it's unstable, and it can easily dislocate. We usually measure this in X-rays or CT scan, where we measure the inside-salvat ratio or Cartan-Deschamps ratio. These are the normal indexes, and for inside-salvat, when it is more than 1.2, it's patella alta, and it is prone to dislocations. In this case now, if the patella is very high, it's patella alta, we usually do distalization of the patella. This is one of our cases where we did the distalization of the patella. It was because of the patella alta. And we usually measure it operatively. We measure the inside-salvat ratio, and we measure exactly the part of the size of the bone to resect. In this case, we were required to resect this much, and we distalized. So the patella and the extensor mechanism comes down, and you treat the deformity. The other cause is the patella goes down when it enters the trochlear fossa. If the fossa is displaced, it can cause dislocation. This is a CT scan of the patient with dysplasia of the trochlea on the right side. As you can see, when the patella, when the patient flexes the knee, the patella goes and bump on this side of the displaced trochlea, and it's not guided into the trochlear fossa, so it can dislocate. This is the diagrammatical presentation of the displaced trochlea. In this case, if you want to treat it, you have to treat it dysplasia by doing the notchplasty or trochleoplasty. The bump is resected and it is reconstructed. This is the picture of the trochleoplasty, where the displaced part is resected and the trochlea is recreated. The other cause is torsion, usually femoral torsion. If the patient has torsion of the femur, when the patella comes down, it is usually aligned with the tibial tuberosity, and when it comes down, it is pulled lateral because of that torsion, and then it dislocates. This one is treated by osteotomy. derotational osteotomy. The other cause of dislocation is pathological TTTG distance. This is the distance between the trochlear fossa and tibial tuberosity. It is usually measured in CT scan or MRI scan. When measuring this, we superimpose the two images, which shows the trochlear fossa and the tibial tuberosity, and we measure the distance between the two. The normal distance, it should be less than 20 millimeters. If it is more, meaning the patella is more laterally, and it pulls the patella lateral and it will dislocate. In this case, if you want to treat it, you have to do osteotomy of the tibial tuberosity and medialize the patella. Now, the aim of the treatment for patellar instability is first to achieve stability and also to prevent or treat condyle lesions and to prevent arthritis. A radiological evaluation was presented, so I'm skipping this slide. Now, the treatment, there are many treatment options. First is non-operative treatment for the patient who are not fit for surgery, and for those who are skeletally mature, when you don't want to operate and if the pathology is born until they are skeletally mature. It includes stretching usually of the lateral structures and strengthening of the quadriceps, especially the VMO. Also strapping and the taping of the patella and the core strength. For surgical treatment, we have to divide the patient in two categories: those who are skeletally mature and those who are not skeletally mature. For patients with skeletal maturity, we have to diagnose the cause of the dislocation. If it is bone issues, we have to deal with bone issues. Because of the repeated dislocation, the medial patellofemoral ligament becomes lax, so we have to fix it on top of the bone procedures. So in our practice, we usually fix the MPFL in every skeletal cause of instability. For skeletally mature patient, it is a challenge to treat them. We usually do soft tissue procedures and wait for some time. So here we have to cancel the patient. That when he will be skeletally mature, we can do another procedure or the possibility of the recurrence of the problems. Sometimes you can do soft tissue procedure and growth modulation, like a pseudodesis on one side to correct the angular alignment. In conclusion, I can say that single surgery cannot solve all the problem of patellar instability because it is multifactorial, and you have to identify all the pathologies for planning, and each anatomical malformation has to be treated. And if you have bone problem, you have to solve it by bone procedure, and soft tissue procedures will not solve the bone problems. Thank you.
Thank you, Dr. Is there any questions for the questions? Maybe if I may ask, how would you tell a young guy to separate examining for patella alta and unstable patella because of PFL. When the difference in clinical examination other than by X-ray, number one. And then when you say soft tissue procedure, for somebody say 8 years, what exactly do you do in your practice? What soft tissue procedures do you do? Okay.
Thank you. For the first question, in patella alta, the patella is usually highlighting, so you can pick it even clinically before doing X-rays. That's usually I do that. For soft tissue procedure, I usually do reconstruction of MPFL. In skeletal mature patients, I usually do dynamic reconstruction where I detach the hamstring, one of the hamstring, usually semitendinosus, and reattach it on patella. I usually use sutures in skeletal and mature patients.
Good. Also, maybe sometimes when you bend the knee, if it is an altar problem causing instability, you are not usually able to hold the patella from dislocating. Usually, you've reached 30, it is already out. Then you should consider the cordyceps mechanism to be a problem. And then the others you can actually resist. For MPFL, when you resist, it engages and it goes very well. But when the patella is high riding, once you reach 30, it jumps and there's no energy that you can hold it to keep it in place, and then you know there is a problem. The British have described a method of doing soft tissue. You should look at the patella almost like a person on a boat, like this, throwing the boat and being pulled from in front. So this extreme use of lateral release, I don't know what is being discouraged, because if you remain with one, then the other side can bend you off. So they don't like lateral release. They're advising that we be sorting the patella tendon itself. So split the patella tendon into two halves, implicate one, and overcover the other one to bring it down for altar, instead of using semitendinosus. I don't know if you look at the patella tendon like that, split it into two by dissecting. Then the lower one you imbricate, and then this one you over. By dissecting it off the patella, then you bring it up. They have some nice paper coming up. See if you can share it with the EAS, the EAS website. Good. Any question on patella instability? Yes, doctor.
Lateral release alone now is being discouraged because it is bringing bad results. But if we could do, if you're doing, if it is deafness or luxation, dislocation, you could do, if you do the lateral release, you couple it with a middle retinacular riffing arthroscopically. The middle retinacular riffing arthroscopically, you can treat with PDS, you don't need any other complicated switches. If you put 3 loops arthroscopically on the middle retinaculum, you find that the results are good, long term.
Thank you very much, Dr. George. I think we can now invite Dr. Mutiso to present. You present 2 topics, Dr. Mutiso, in succession. We start with the topic on disease. So, yes. This one. We can just use this one.
So I'm going to present on PCR. I think yesterday, also a bit of today, we looked at SEM.
No, just put good. Okay, you can hear me.
I'm going to look at the PCL, and it's supposed to be video. There are lots and lots of videos actually in PCL. And they are encouraged to look at the different ones because they're quite educative. And my colleagues helped me pick just two relatively short ones for us to look at. And then I will look at the posterolateral corner. And then my brother there will wind up with looking at all the ligaments together. Okay, so this is a fairly short video. It's an inline PCL reconstruction with arthritis. If I just mention a little bit about the clinical part, normally the posterior cruciate stops the tibia translating posteriorly. The posterior cruciate, the tibia translating posteriorly. Okay, so those are easy to test. It is very difficult to find an isolated PCL injury, and many times we find it almost accidentally, and very often we do not bother to repair because the patient does not complain that much, and they can function reasonably well with that. So the times when PCL is injured, often it is in association with something else. So which are the best tests? Posterior draw test, which I think you all know. The patient is supine. You put the knee at 90 degrees, and then you pull it forward. But remember not to confuse the tibia moving forward with an ACL injury. Remember the normal knee. Now the sensitivity is maybe about 90%, 80 to 90%. And part of that reason is that there's no proper endpoint when you are doing the anterior draw test, for the posterior draw test. The specificity is a little better, maybe about 90%. But the best test, which is almost 100%, 90+% in terms of sensitivity and specificity, is the posterior sag. This one, again, if the patient is supine, they lie with the knee at 90 degrees, and often the knee will fall back on its own, and you can see it from the side. If it hasn't fallen back on its own, you can assist it to move a little bit back, and you'll see that. So that test is very, very sensitive and very, very specific, and you really do not need much else from that. So we start off with this very short video, and like I said, my colleagues helped me pick it up because there are hundreds and thousands of these. Let's see what this says.
Ligament reconstruction with the PCL tightrope is a technique used to allow minimally invasive reconstruction of a torn posterior cruciate ligament. If the posterior cruciate ligament is not repaired, meniscal tears and arthritis may occur in the knee. The surgeon begins by flexing the knee and introducing a guide through a small incision on the front of the knee. The guide is placed in the original area where the PCL attaches on the lower leg bone. A special pin called a flip cutter is drilled through the bone and into the joint.
So we are not representing this particular company in any way. It's just an example of what you can do. Now the important thing here is that this is really far posterior. So you would not see it with an ordinary 30-degree scope. Yes? So you need something which is like 70, or you can have another portal from the back. Okay? So in order to see that spot.
Part of the drill guide is tapped into place with a mallet to facilitate drilling. By pushing a button on the flip cutter, the tip is rotated into a cutting position. The flip cutter is then drilled back into the bone to create a socket where the graft will eventually be placed. The flip cutter is removed and a suture is passed into the joint and out of the skin for later graft passing. The tendon graft is prepared to match the socket created by the flip cutter. The PCL tightrope is secured to the prepared Achilles tendon bone block. An additional suture is added to secure the button to the tendon. The graft is introduced into the joint by pulling on the PCL tightrope implant. A button is added to the PCL tightrope. The graft is now secured into place.
I think we saw this flip cutter in yesterday's presentation for ACL. The main point is that you're getting a tibial tunnel which is coming out at the back, a difficult place to see. Now, it's not really a joke about that back, because remember the structures that are there. You have arteries, nerves, at very close to the joint. So if you misbehave there or you're not careful, you can go and damage that, and then that will be a disaster. Instead of you repairing a PCL, you'll be amputating somebody's leg.
The remainder of the tendon graft is passed into the upper leg bone and secured. The arthroscopic inlay posterior cruciate ligament reconstruction with the PCL tightrope technique allows the graft.
Now you remember your anatomy. The femoral tunnel is now medial, yes, because this is PCL. Now remember that if it is a PCL tear, it's not as easy as it appears on this diagram, because the ACL is intact and the ACL is at the front. Yeah, we are together. The ACL is at the front, so it looks relatively easy on this. After all, it's a model. Of course, it's a little more challenging than that.
Graft to enter the knee through a small anterior incision and avoids the traditional large posterior incision on the back of the knee. The PCL inlay reconstruction technique may lead to less graft abrasion and better approximation of native biomechanics.
Yep, that's it for that. We'll now move to the next one. The next one is arthroscopic. So
when a combined ACL-LCL injury occurs, one may feel or hear a pop, followed by swelling.
Hear a pop, see or maybe. We are now going to go to the second video. This one is an arthroscopic video. I think it will be more clear. Now that you've seen the model, the one on the models, it's easier to visualize what it is that's going on. Let me make sure I get the right one. So this one is the PCL, knee arthroscopy for PCL.
Narrate to them during surgery while they are asleep and provide to them on DVD. The example video you will see next is a shortened version of the actual surgery video I provided to this patient. The patient gave permission for online publication of this video.
All right, Katie, this is Dr. Eisenberg and the team. We just got into your knee joint here. What you see in front of you, this is a blue cannula taking fluid outside of the joint. Coming through that blue cannula is a probe. You can see each hash mark on that probe is 1 millimeter. The tip of the probe is 1 millimeter, and the length of...
So we are assuming we're already in the knee. Remember your portals, how we are getting here. You all know what this is. It's basically, for those who were in the wet lab yesterday, you remember we make the portals and some of the membranes would balloon out. Yeah. So with this, I know you all know it, but I'll just say, with this, it kind of seals the portal that you have made so that it doesn't leak. It can still leak, but the chances are much less. Now, you remember the probes, the improvised probes that we were using yesterday, but this one doesn't show it so clearly, but some of them are marked in terms of the sizes there. And of course, this is highly magnified. This might be like 2 millimeters or 2-3 millimeters of that for you to see.
where the tip is 3 millimeters. The hole in that cannula is 3 millimeters. It's to give you an idea of magnification. Now, before your surgery, I took an examination of your knee, and it was buckling as expected with a PCL tear as well as an MCL tear that is not scarred in despite taking time and rehab. So everything is as expected so far. What we're going to do is we're going to take a look around your knee.
The patella's up there.
Okay, here we go. This is your ACL, and you're looking at it. It seems like it's a little loose, but that's just because your knee is sagging.
So it's what I was saying earlier. The ACL is right in the way. This is a nice looking ACL actually. It's not too bad. So you probe it, check its viability.
Posteriorly due to torn PCL, which is up here. So I'm going to have my assistant here. He's going to do a little anterior drawer. So go ahead and pull. And you can see there's a nice tight ACL. I'm going to take a picture of that.
Anterior drawer.
And that's again just, it seems a little loose, but that's only because PCL, which is just to the left here, is torn. You can actually see some of that scarring way all the way in the back here. I'll take a picture of that. So we can go ahead and open.
Judging from that scarring, is it a fresh injury? Is this a fresh injury? Probably not. You can see the scars there on the PCL.
In the graft. So we're going to look at the medial compartment of the knee next, and we're going to start cleaning up. Here we are on the medial compartment of the knee. You can see I have a probe here as well. We're looking at the entirety of the medial meniscus, and it looks perfect all the way around.
Is this a young person or an old person? Young, eh? You can see the pristine looking meniscus. But remember, in these ligament injuries, many of them have the menisci damaged. So even when you're doing this, it's good to also probe the menisci, make sure you're not missing an injury, which you could repair. And if you miss it, your results may not be as good.
Which is nice. This is one thing that's not damaged. Again, your medial cartilage looks good as well. We're looking at here, these are some of the fibers of your PCL that are torn. I'll take a picture of that. We're going to get started on cleaning up some of this area, and we'll look into the back. We just put a cannula in the back. This is a very back posterior medial recess of your knee. As we go out, we're going to see your PCL remnants right there. Okay, I'm just taking down some of this synovium and fat pad to let us work what we have to work. Okay, here I'm just taking down some of the residual stump of your PCL. You can see here.
You could see the fast forwarded, edited it. So now, remember the old ligament is still there. It's just that it's torn. So if you're going to repair and without clearing up first, then the knee will really get stuffed and you'll not get a good result. So one of the things you need to do is to remove as much as you can of the old ligament in preparation for your grafting. The ones who are in the wet lab, one of the tables had this shaver. I think some of you tried it.
The remainder fibers of your anterolateral bundle of your PCL here. We're just cleaning that up. We're going to prepare the notch. Then we're going to look at the tibial plateau part. Okay, here we go. We're looking with a 70-degree arthroscope now. It has a little bit of a different angle, and we're looking down the back of your tibia. And here's a shaver we're using. Again, this is the footprint of your PCL. It's a large ligament. We're going to just follow that footprint. We might even leave some of it to protect your nerves and arteries, which are right literally behind here, that we have to try to protect.
Just look at the size of that. Look at it, it's really big. Eh? And if you compare with the footprint of the ACL, this is probably more significant. Why is saying that he wants to leave a portion of it? Like we said, there are vessels behind. So you just remove the anterior part, the one at the front. You know, if it's flush enough, then you're not really going to end up stuffing your knee so much. But it's giving you access to the posterior part, the posterior slope of the tibia. Whilst what you've left behind helps to protect the vessels that are behind.
Okay, here we go. I'm using, this is called a werewolf. It's a little bit of a ablation wand. What it does is just burn some of the tissue off. And we're looking again with a 70-degree view all the way down the back of your tibia, see until we fall off, which is going to be around there. And again, being really careful to protect all the nerves and blood vessels. Okay, here we are. This is the back of your tibia, and you can see with the shaver, I drop off right over the very edge, and that's where I want to be with my PCL guide. And you'll see that in a little bit. We're going to clean up a little bit of this. This is the PCL remnant we still have here. I was using it to kind of protect like I told you earlier, the back where you have the most important part of your knee. We're going to clean that up for later for when we pass it. Okay, we're coming in. This is us looking from the back to the front. Here's the PCL guide coming in around the corner.
Just look at that guide.
For when we pass it around. Okay, we're coming in. This is us looking from the back to the front. Here's the PCL guide.
Just look at that guide. It's quite broad, isn't it? So when you're covering the back of the tibia, it's quite protected, so that should you make a mistake, it's going to enclose the passage you're making through the tibia, so that you don't injure the vessels behind.
Guide coming in around the corner. I'm going to just dunk it in this area. Can you hold this for a second, Roger, so it doesn't fall? And I'm going to look down. This is where we had debrided your PCL footprint, and I'm putting that guide where I have to be, and I'll show you what it looks like once we're there. We're going to be ready to pass the pin in a minute. All right, Katie, here we go. There's that pin way down. Here's your popliteus muscle there, and this is the pin for your anterolateral bundle reconstruction of your PCL. All right, okay, here we go. This.
Remember where the popliteus is, eh? Remember popliteus? I'll talk a little bit about it in the next talk. So the popliteus is right there behind. Yeah, and then the PCL is just about it. A number of the ones of the PCLs I've repaired has had an avulsion fracture. The actual ligament is intact, but it's come off the bone. So you approach it from behind and you repair and you fix it from the back.
This is a flip cutter, and I'm using this instrument to protect the back, and I'm going to start drilling, and then we're going to make a PCL. Okay, here we go. I'm taking the end. I made that drill hole. It's down in there. I passed this passing stitch. I'm going to pass that. Follow me in a little bit with that. We're going to pass that out of the front portal. It's going to be used to help pass your graft. You can see the remnants of the fibers from your old anterolateral bundle there. So we're going to just clean that up a little bit to make sure it's nice, good bone. We're going to leave the fibrous remnants of the other parts of the. Here we go. This is the pin for your femoral tunnel. We're going to get it more in there. We're going to flip it. We're going to make sure it's in a perfect spot. We're drilling your femoral tunnel now. You're going to see this flip cutter coming back.
Remember that those radiofrequency ablators are special. If you get cheated and you use one of the older models, you boil your joint. Remember, it's heat. It will heat up there, and then you'll end up with a boiled joint. The modern ones are specially made so that they don't damage, they don't cause heat. Of course, we also have our water flowing, which helps to produce.
Okay, here we go. Yep.
And there are also different types. I think one of the news were shown, there was a different type which was shown. Huh? Which talk was it? There's one where we were shown one which burns slightly different. So keep in mind that they're always different. When these guys who sell these things come to you, make sure they explain to you what the properties are. It might look cheap, but then that cheapness might turn out expensive.
We have that 11 o'clock tunnel nice and tight next to your articular surface. And we have the tibial tunnel back there. What we're going to do is we're going to get ready to pass your graft. Okay, here's your graft coming in. We're going to get it around this, what we call the killer turn. I'll show you. All right, here we go. Katie, we're just pulling this graft into your tibia. Now you see the very end of it. We're going to pull that through your femur, and then we're going to fix it on the femur and then pull it through the tibia again. Okay, here we are. We're all done. It's a little bit oozy in here because we took the tourniquet down here. What you're seeing is your ACL here. It's a little bit more tension here like we wanted. Here's your PCL, the very 11 o'clock of your tunnel here. Nice and snug here. You can see it's a little bit bulbous here. This is just from the swelling while we were working on your medial collateral ligament, which we also fixed with what we call an internal brace. There's no cadaver ligament there. So you did great. Make sure you have lots of ice. Call me if you need me, and thank you for your trust.
Okay, thank you very much. That is it. I know it's after lunch.
Any questions for Dr. Mpiso's presentation of PCL, or should we move straight to the next? Any questions on PCL technique? This is all inside. Also, I think you can also do.
Yes, you Actually, in training, you always need a default. If you're going to do closed and you don't know how to do open, and then you get stuck, what are you going to do? So you must always know how to do open. It's just like any other place in the body, whether it's the abdomen. Yes, you can do things closed in there. When push comes to shove and you're stuck, you open and you do it. And it works. It works, yeah.
We go to the second presentation to posterolateral corner injury. Yes. Diagnosis and management.
Hope you can find it. I'll request everybody to stand and stretch. At least that I know you're awake. Simame. Stretch. Oh, some music. Thank you. Can sit. Remember, these exercises are what made some of those industrial countries take off. Right? In Japan, they used to do calisthenics every morning before they start their factory stuff. As of now, Mali was Mufika. Whilst the rest of us, sometimes even waking up in the morning is difficult. Okay, the next topic is posterolateral corner injuries. Now, this is a topic we rarely talk about. I'm not sure why. We rarely talk about it, and I think the organizers made sure the HTO and posterolateral was a deliberate inclusion in this course. It's known as the dark side of the knee because we rarely bother with it. Or even when we see the signs, we tend to want to ignore it. You pretend yosikuona, concentrate on ACL, concentrate on PCL, concentrate on MCL. MCL you like because usually you don't do anything. You just put a brace, you say, mimi nimediagnose MCL, naweka brace, so posterolateral corner doesn't just go away. Usually you will have to do something. And therefore, try and stress that. Stop. Now, what is posterolateral corner? If you know your knees, you know your anatomy, there are certain structures there that are key. And then, of course, there are so many structures. If you look at an anatomy book, it depends which book you are looking at. There are some which are a lot more detailed than others. If you look at Gray's Anatomy, for example, you will just be surprised. The number of ligaments crisscrossing all over the place. Many of them we don't even know. Once in a while, just open a Gray's Anatomy. Even this patella we were talking about, you'll be surprised how many facets there are on that. Who can guess how many facets there are on the patella? There are certainly not two. There are very many. Yeah, so it's just a question of how much detail and how important it is in the learning process. So the primary stabilizers, lateral collateral ligament, we all know that one. We are always checking on it. We know it. There's the popliteus muscle tendon unit. We don't like to think about it much, but you remember it was mentioned when we were doing when we were looking at the PCL repair. Then there's the popliteofibular ligament. Rarely do we even think about it, and yet it is a primary stabilizer to lateral corner. We very rarely think about it. Okay? Then, of course, secondary stabilizers are many. We've tried to pick the ones that are a little bit more important than others. So there's the lateral capsular thickening. What is that? You know the capsule goes around the whole knee. At the back there, in that area, it's thickened just a little more than it is in the rest. And then that is a secondary stabilizer. The fabulofibular ligament. Who can tell me where that is? I'm sure you've come across it in the past. Did you come about Amani? Then there's the coronary ligament of the lateral meniscus. Do we ever think of it as a stabilizer? No. Lateral head of gastrocnemius. Now that one we know, gastrocnemius, usually when you get your supracondylar fractures, you want to, if you're doing something, even when you're operating, but if you're treating conservatively, you want your knee flexed so that it is relaxed, so that it doesn't bend. Your knee, your femur can heal straight. Okay. Now in that lateral head of gastrocnemius, you remember there is a bone in there, which is next to the bone. If you take an X-ray, a lot of the X-rays you find there is an osseous part behind. Sometimes you're wondering, is this a foreign body or what is it? Now that is the fibula. That fibula has a ligament that goes to attach on the styloid process of the fibula, and it is an important secondary stabilizer. Long head of biceps femoris. This one, we know about it quite a lot because when we are doing our LCL clinical examination, we know that our biceps comes and attaches to the head of the fibula. Yes. So if you have an important muscle of that type, which is crossing two joints, coming all the way to hold on to that fibula, yes, you know it must be important, and it must be playing a role in stabilizing that part. Okay? So at least that one is not so strong. What about the acute ligamentous complex? How many of us think about that as a secondary stabilizer? Not many. I certainly hardly ever think of it until I have to do something concerning this area. That's when I remember, oh yes, there is something else. Now, these are the more important secondary stabilizers, but there are more. Like I said, if you look at a Gray's Anatomy or one of those big anatomy textbooks, these things are literally crisscrossing the whole of that area. Now, I've put this variably present because in anatomy dissections, there are many, many cadavers which will not have it. Okay? And it depends on the set of cadavers that people are working with. Up to 48% may not have it, but it can go up even up to 64% of not having it. It's a little bit like our palmaris longus. We all have our palmaris longus. Kuna mtu ana miss hiyo palmaris hapa. Okay, you've never probably looked. Yeah. Apparently, if you are missing it, you're probably more evolutionary advanced than the others. Now, when you're in this area, there are also other important things that are passing by there. You need to keep them in mind because this is surgery. Cut something, either repairing it will be a big hassle or you may just cause damage that your patients will be unhappy about. So you need to keep these things in mind. Common peroneal nerve. This one many of you do not forget. But remember, like in HTO when we were talking about it, the fibula, small as it is, it's an important bone. It's a very important bone. We tend to cut it and do all kinds of things with it. But remember what it does. Your talus is large at the front and narrow behind. When you dorsiflex your foot, it pushes on the lateral malleolus, and the middle of the fibula goes inwards. It's like those springs on pickups and trucks. Yeah. So if you disturb that, much as we are getting away with it, there is definitely an effect because that spring loading is disturbed. Even when we put our screws, when we are doing ankle joints, you put your screw, your syndesmosis screw, I know you're putting it for a reason, but you are disturbing that motion. That is why, as much as possible, at 12 weeks, you get it out, so that you're not disturbing that value of that. So that's a bit about the fibula. So common peroneal nerve, remember where it is passing. It crosses at the neck of the fibula. If you're going to be operating in that area and you're not keeping that in mind, you do a good job with the posterolateral corner and you do a bad job with the foot. If they have a drop foot, they'll not be happy at all. Posterolateral corner primary restraint against varus stress and external rotation of the tibia. And so posterolateral corner, remember the structures we said are there. Yeah? LCL, what does the LCL do? Lateral collateral ligament. Whenever we are testing it, and we do that very often in the clinics and so on, you apply a varus force, and it resists that varus force. Now, this is the most important ligament as far as varus forces are concerned. In fact, it's been shown in the people who want cadavers and do research that you can remove all the other restraints for against varus, and it will still be doing its job, especially when the knee is at about 30%, 30% of flexion. So that's why I put it there. LCL is the primary restraint to varus. Now the popliteus unlocks the knee joint. Remember the popliteus, what it does? It's at the back of the knee. It has a tendon. It goes through the joint, past the lateral meniscus, attaches to the lateral condyle of the femur. When it contracts, it does an internal rotation of your tibia. When it internally rotates, it unlocks the joint. Remember, when we are standing up fully, we are using very little energy. If you try to stand like this, you are using energy, and you'll not be able to do that for as long as you can when you are standing up straight. Okay? There is no change in external rotation stability after release of the PCL. Okay, this is a little bit magnified in that particular area, but I put this here deliberately so that when you're doing a repair, you know where all these structures are. Now, I don't have a pointer, so I'll just use this. I hope it can. Can this one be seen? I'm not sure. So this is the lateral collateral ligament. Can you all see it? Yes. That's the lateral collateral ligament. Remember, you're going to be in your reconstruction. In your reconstruction, you're going to be making holes in your femur. So you need to know where your structures are passing. If you don't know where they are passing, then how are you going to know where to put your holes in the femur? Because if you are doing it by guesswork, the chances of damaging something are very high. So there's your lateral collateral ligament. It's attaching to the lateral epicondyle of the femur. Yeah? Now it's not right spot on it, it's a bit above and behind. Okay? And then it comes and attaches on the fibula down here. This is the styloid process of the fibula, and the fibula goes down. So just look at this. It's not attaching up here, it's attaching lower down. Usually it's about 3 centimeters or so below. So in our minds, you're always thinking, okay, you know where it comes, generally, but you're not very specific about where it is. But now you need to be a little more specific, so that when you are doing your reconstruction and repair, you know where things are, but not damaging things. This is the lateral condyle. This is the lateral condyle. And lateral condyle iko hapo. Condyle is somewhere here. This is attaching a little above and behind. This is coming and attaching a little lower down on the fibula. Yes? And look where the popliteus tendon is. It's coming from the back of this knee, yes, proximal tibia, and passing through there and attaching up there to the lateral condyle. Now, this is the lateral head of gastrocnemius. Lateral head of gastrocnemius is LHG. Yes. Obviously, it is something which is good because this, you see the styloid process. So the muscle which is missing is the biceps femoris, isn't it? Because it comes to attach there. Now, one of the important guys is this one, common peroneal nerve. You see where it is? And usually when you are operating, you'll have to lift. You know it's coming from your biceps femoris, utaangalia pande hiyo. Now, what else is here that is important? Yeah. Other thing that is important is the iliotibial tract. Remember, it attaches. It attaches in front here. Why is it important? When you're operating, you flex your knee, you extend. Remember, when you flex the knee, this moves back. The iliotibial tract moves back. Yes, when you're flexing the knee, it moves back. So it becomes almost like a flexor of the knee. And when you extend, it is an extensor of the knee. Very many times we forget about this, but you need to have it in your mind because you want the knee to be tensioned properly at the time that you're doing it. So what is the common clinical presentation? I think we all know. Usually, this is a result of high energy injuries, which is why it tends to be part of a multi-ligamentous kind of picture. At least one of these others, either the ACL or PCL, will be injured. So how many times is it injured in isolation? About 1/3 of the time. The posterolateral corner will be injured in isolation. And the ones which are injured in isolation, we tend to overlook. And then, actually, it's a bad thing because either way, we tend to overlook it. When it's part of multi-ligamentous injury, again, we kind of overlook it because you're looking at the ACL, you're looking at the PCL, you're looking at the MCL, then this goes kind of far back in your mind, and yet it is quite important. So, how do you make sure you find it? Have a very high suspicion. Now, after high energy injury, these fellows are in pain. So we're not really going to examine them the normal way. So for you to find out that these things, there's a problem there, you have your high suspicion, and also you need to do investigations earlier. So an MRI in this case you want to do early. Remember, these questions always come up. Do we do an MRI early or do we do it late? In this case, we want it early, although we know there's edema in the tissues and the pictures that you see will not be quite what you expect. It's good to do that early. And then you must compare the knees. Clinically, this is one of the first things you do when you're doing the clinical examination. Inspection, you're comparing the two. Do they look alike or not? If they're not looking alike, what's the difference? Is one swollen or not? And so on. So you compare that, it increases your suspicion, and then you specifically look for these injuries. Now, the chronic cases are the ones who are now coming late. Usually, if it's subacute, maybe 6 weeks. If it's properly chronic, more than 6 weeks. And these ones, you can ask them to stand. You check the alignment of the knees. They can lie down, they can stand. Remember, the acute cases will not be able to do that. So you can assess their gait. Okay, you can assess their gait. So when you ask them to walk, they get first of all the knee alignment will be in varus, like this, because this is what is preventing varus. So if it's disturbed, of course you can have varus when they are standing. So that raises your suspicion even earlier. When you ask them to walk, some of them will have a varus hyperextension thrust in the stance phase. Stance phase because it's taking weight, and it is a thrust because that part is not protected. So when the weight goes through, that part is not protected in terms of ligament, so it thrusts backwards. Remember the thrust in Blount's, and you know the direction that goes. So this will be something similar, but more posterior lateral. One of the things you must not forget is a neurovascular assessment. Remember, the common peroneal nerve is passing around there. So do not ignore that, do it. Doing a neurovascular assessment sometimes is difficult because the patients get tired. You ask them, can you feel this, can you feel that? They say yes, they say no. You ask them to close their eyes, they're peeping, and then they get tired. So they may, just to give you an answer, they can say yes, yes, no, no, just to keep you out of the way. So you have to be careful that they're telling you something that is closer to what is actually happening. Then I put that figure there deliberately. About a quarter of these patients will have a problem with their neural status. So it is not good to ignore. Of course, you have to examine the other ligaments, and there is a presentation coming on multiligamentous injuries. Now, there are a number of tests that we do. You all know them. There's the dial test, where you're checking the tibiofibular angle. Now, this test can be done with the patient either supine or prone. Most people prefer prone because you can bend the knee like that. And if you have about 10 to 15 degrees of rotation at 30 degrees, that one is the PLC. If it is at 90 degrees, then it's a combination of the posterolateral corner and the posterior cruciate ligament. I just put this in here. Here, you see this is at 90, this is at 30. This is the dial test. Basically, the patient is lying on their tummy, the knees are flexed to 30 or to 90, and then you dial them out. You dial them out. When you dial them out, you check the angle between the tibia and the foot. Yes? Now, if it goes beyond 10-15 degrees, then you know there's a problem with that piece, posterolateral corner. Okay? So here is supine. Now, when it's 30 degrees, then you are really looking at the PLC specifically. When it's at 90 degrees, you are looking at both the PLC and the PCL. Yeah? Now, this is the same test, but it's done with the patient supine. The patient is supine, and you're putting in a valgus, a bit of a valgus first there, laterally rotating that. So it's a dial test because you are measuring the tibia foot angle. Now the other tests, there are many, and it depends which test you look at. But some of the more important ones are here. Varus stress test. Okay, at 0 degrees, looking at the PLC plus ACL, PCL. That could be a combination of injuries. At 30 degrees, it is strictly LCL. And this is what I was saying earlier. So if you're checking strictly LCL, whenever you are doing, remember you do your Lachmans at about the same angle. Keep that angle and you do your varus stress test. And if it is intact, then you know your LCL is intact. At the other angle, it could be a combination, yeah, of those other. There's the reverse pivot shift test. I know you all always think about the pivot shift test, which we do for ACL. This is the reverse pivot shift test. And I'm only mentioning it because you have to be careful. You must compare it to the other side. Because in up to a third of the patients, it will appear to be positive, and yet it is similar to the opposite side. Try and keep awake, karibu namaliza. Then there's the external rotation recurvatum test. Very easy. The patient is lying on their back, okay, and you stabilize the thigh and you lift the leg with the big toe, okay. And there you will get a recurvatum. Pivot shift test is for ACL. I think you all know what that is. Classification, again, there are many. The easy one and the one I like to remember is this one, the Houston et al., where it's divided into grade 1, 2, and 3. Obviously, grade 1 is not so bad, and grade 3 is the worst. So we've just had a presentation on X-rays, on radiology. When you get a gapping of up to 5 millimeters of gap, and you're getting up to 5 degrees of rotation, that is grade 1. Up to 10, between 5 and 10 of gapping and 5 and 10 of rotation, that's grade 2. And anything above that is grade 3. Now this grading, is it useful? Yes, it is. A lot of the classifications we do are for a reason. It gives you an idea of how you are supposed to manage. It guides you on how to manage that particular injury. There's another classification there which some people like, the Fanelli and Larson. I probably won't go into it, but it's type A, B, and C. And of course, as you progress A, B, C, it gets worse. So imaging, like I said, we just had something on imaging. What is it you look for? This guy most likely was through a high energy injury. Okay, so you look for fractures. Are there fractures there or not? And remember, there are fractures. Many fractures we miss because this patient, especially when they are multiply injured, you look at the main things that they are injured from, and there are few fractures that you miss. So it's always good to, even the next day, you just go examine your patient fully, and you'll be surprised. And we see this even when during some of the trainings we used to do for advanced trauma. Our candidates would, when they find one injury, it's like they are satisfied. And you tell them to look for a second, and they look and they find it. When you find the second injury, usually you don't feel like looking for a third. And yet there may be a third, there may even be a fourth. And I know this happens frequently, especially our multiple injured patients. We find 2 or 3 injuries and we miss another two others. The ones missed most are in the hand and in the foot. Because you've gone, you've done your interlocking nails and so on, and yet there is a fracture in the foot that you have missed. So look for soft tissue swelling, you can see that on X-ray. You look for joint space widening, you look for fibular head avulsion. Remember the biceps where it attaches, so that can avulse. The anteromedial tibia fractures, acute sign. Again, that's just an avulsion fracture with spine. Right? MRI, again, these were mentioned, T1, T2. Remember, there's also proton density, yes? Remember, there's fat saturated, there's gradient echo, a few others, and it depends what it is that you are specifically looking at that you want to highlight. This is an example. Okay, it's not as clear as I would have liked, but here you can see there is hyperintensity there. We know that's in the fibula, so there's something which was attaching there. You find out what it is. And this one, you see here, there's a break. This is the lateral collateral ligament, the Katika apple. In this one, again, these are very poor images, I'm sorry. But what I'm saying is that look at this. If you look at them carefully, there's quite a lot that we can show you. How do you manage the earlier cases, the acute cases? There are some which you can do a primary repair, but in general, primary repairs don't seem to work very well. But there's room for it, and you can do a primary repair. Especially if it is bony, then because bone, once you've attached it, put a screw across or something like that, it will heal. When it is more soft tissue, it's tricky. You may want to augment or brace and so on. So a lot of these injuries are severe enough to require reconstruction and winding up. So these are the popular methods. Now, remember how many things we said are injured. But look how simple, relatively simple the repair is. Relatively simple. So you just put this is just across. This is coming from front to back, and this is coming from back to front. That's one ligament, and you've done something good for this patient. Then you can advance. This is the popliteal tendon over there. We incorporate it in this. Okay. Now this is different from this. See, it's coming from the back, going to the front. This one is not going to the fibula at all. But the ones, this is the Larson's, quite popular, and this is a modification of Larson's. You see there are two attachments on the femur. Now this one is Laprade. You know, Laprade is so famous in this work. I think after a while, when you're so famous, you get bored. You want to see if you can do a little more than everybody else. So there is this. But the literature does not say that this is better. It takes you longer. Making these channels is more difficult. Look, there's not here. It's going just all the way through here in your ankle. Then there are other anchors here. That takes time. And then getting the exact correct spot is also difficult. So we would not recommend that you do this unless you're really feeling like today, you really know this stuff and you want to show off, right? Now, advantage of this, how many tendons will you need for this? It means you have to do more harvesting and all. Here you just need one tendon. And probably this is the one which is getting the best results. So what am I saying here? Complicated injury, potentially very troublesome, but the solution is relatively simple. Relatively simple. So now we really do not have a good excuse to be ignoring posterolateral corner. Thank you very much. Can I just say a very quick one on rehab? Yes. Okay, rehab, it's obvious, so I'll be very quick. Range of motion, remember anything at the end of the day, you want function, isn't it? So range of motion, you start early. There's muscular endurance, there is strength, there is power. Remember, there's a difference. Endurance, strength, and power are not the same. So remember that. Well, you want knee flexion by 2 weeks, and you crutches away, and then you want to be able to do your full range by 8 weeks, full flexion, full extension 8 weeks, full flexion 12 weeks, sports in about 8. Okay, I end a second time. Something. Yeah, people are really dozing. The course is nearly ending. Changamke kidogo. Reduced, we are exhausted, stretch a bit.
As you ask your questions, please.
Questions for Dr. Mutiso.
Yours is forward, Dr. Kari.
Thank you for the presentation, Chief. My question is that most common we get someone with horizontal injury probably with ACL or PCL. So which one do you like to start with? Because I find that on the ACL we are all touching the lateral area as well. The screws will be going there. But maybe with that regard, if someone's PCL and post-lateral corner injury, if you're going the other corner. So first of all, if it has ACL and post-lateral corner and PCL, which one do you start with? And then extra-articular, intra-articular, and then same sitting or different setting.
How we can sit down.
That's a good question. Every case on its merit, and I think my colleague is going to cover multiple joint injuries. The last patient I did, because we had to do metal work, so the SCL, even if I wanted to repair it, I couldn't. There was crisscrossing. But when I was doing posterolateral corner, I'm opening from the side, and I also have access to the back. And there was an avulsion fracture, which was causing the PCL to be weak. So I took that opportunity. I just put a screw to hold the PCL, and then I did the posterolateral corner. So every case will be different. You have to judge it according to what there is at that time. Anything else? No, I think they are.
Thank you, Dr. Mutiso. I think he has done 2/3 of my presentation. So, and they usually say the last speaker usually will not buy drinks in the evening. So, I have an advantage already. So, that's that. So, by definition, multi-ligament injuries is more than two knee ligaments are involved, mostly associated with knee dislocations. You can have multi-ligament knee injuries without dislocation, but sometimes they say maybe it dislocated and relocated. That's why you don't notice. And they are complex in mechanism and management. These associated injuries have been mentioned: neurovascular. You can see the very good blood supply, the genicular anastomosis, and the nervous supply around the knee joint, quite vast, huge nerves passing by near there. Associated musculoskeletal injuries of the femur, tibia, fibula, fractures of the patella, tear of the quadriceps, patella tendons, injured meniscus, and cartilage injuries can all be associated with these kind of injuries. These are simple classification, the Schenck classification of multilateral injuries. KD1, where you have ACL or PCL plus a collateral. KD2, ACL plus a PCL. KD3, M, ACL, a PCL plus medial collateral ligament. KD3L, ACL, PCL plus a lateral collateral ligament. And then there's KD4, ACL, PCL, medial collateral and lateral collateral combined. KD5 is where you also have a fracture dislocation. With a V, that is vascular injuries. With an N, is nervous injury. This is the same in a different way. And this is the Kennedy classification. This relates to the relationship of the dislocation or the bone, the anterior displacement of the tibia, have a posterior displacement, multidirectional, and rotatory dislocation. Okay, the incidents, they are not common, or perhaps they are underreported. And about 30% are associated with meniscus or cartilage damage, about 50% associated with nerve vascular injuries, and as Dr. Mutiso says, they are high energy injuries by mechanism. Motor vehicle accidents, sports injuries, fall from heights are the commonest. And then you have obese persons. These very obese persons are very clumsy, just stepping down on a small step and they'll twist the whole knee. I was just looking at the statistics the other day. Like almost 10,000 people were directly affected by motorcycle crashes from May 2022 to October 2023 in Kenya. So we have so many of these accidents. I've not seen this in Dar es Salaam. This one in Kenya we call it mshikaki. It's very common. So once you have such many passengers in a motorbike, you end up in premium tiers. This again is the incidence which I think I've mentioned. The anatomy, we have the front anatomy, side view. Also, these I think were covered quite substantially. And as you can see on the far right, the posterior part of the knee is highly populated by many of those ligaments and structures. Others we didn't even know exist. That is the lateral side, and demarcating the anterolateral ligament, the famous anterolateral ligament, with the lateral collateral ligament below it. The medial side, you have the medial collateral complex, medial collateral ligament complex. It was first dissected in the 1940s by a gentleman called Gun and Boschall. And it comprises the superficial MCL, deep MCL, and posterior oblique ligament, or the POL. The MCL complex is dynamically reinforced by the pes anserinus, vastus medialis, and semimembranosus expansion. MCL complex static and dynamic resistance to valgus stress. That's the main function. Also, it is a constraint to external rotation and anteroposterior translation of the knee. This is the posterolateral corner, which we have just heard about. The iliotibial band covers all these structures, and the popliteus complex, as it was said, acts as a dynamic internal rotator of the tibia. That's the posterior knee we just mentioned. The PCL provides most of the total restraint to posterior tibial displacement at all flexion angles, and 90% of the posterior stability between 30 and 90 degrees. PCL also acts as a secondary constraint to both internal and external rotation, and a cadaveric study by Morgan showed that the oblique popliteus ligament was the primary ligamentous restraint to knee hyperflexion. The ACL, we have talked about it. Now, this is where the talk begins. Now, acute management. Management of multi-ligament injury patient should be approached, because usually you have it's a polytrauma patient. So there's the acute severe trauma assessment, and then management of the limb. Managing the limb, you have to check the vascular structures, neurological, and other associated injuries. Now, managing the knee, you start looking at acute stability and think about definitive treatment of that knee. So, as I said, the patient management is you have to look at the whole patient in general, as in trauma series. The limb, you have to do a rapid vascular and neurological assessment. You can reduce and temporarily stabilize the knee, and then you repeat again neurovascular assessment and manage other associated injuries. For the knee itself, there is focused clinical examination of the joint clinically, and then there is imaging, and then you plan your definitive treatment. You have to check on limb perfusion by pulses, the ankle brachial index. Anything less than 0.9, 0.8, you have to involve the vascular team and do a CT angiography. Neurological injury, we said, is about 35%, 31%, sorry. It's much more frequent with the PCL injuries. The frequency related to injury pattern. Neuropraxia is more than neurontemesis. So your neurological examination, you have to do a pre and post reduction examination. You monitor mainly the common peroleal nerve. You tell the patient to dorsiflex, eversion power, dorsal foot sensation, which again are not easy to do when the patient is acutely injured. And for the tibial nerve, you look for plantar flexion and plantar sensation. Ligament assessment again has to be systematic. PCL, the tibial step we are told about, posterior drawer, ACL, Lachman, medial collateral endpoint valgus at 0 and at 30 degrees, lateral collateral PLC, varus stress and dial test. Imaging, we talked of X-rays, ultrasound, CT, angio. MRI is the gold standard for ligamentous injuries, so that one you can't do without. That's X-ray, MRI. Surgery is preferred to conservative management. You can temporize the joint by external fixation, can put up a brace or a back slab if you don't have these sophisticated immobilizers. Emergency vascular intervention in case of vascular injury. In case of open dislocation, you have to reduce and temporize the joint again. If you have access to Elixir or ring fixators, the better. Now, usually there is this question: do you manage them acutely, all of them, or you do a staged management? So once you have identified which ligaments are torn, surgical repair versus reconstruction. Acutely, there are some ligaments you can acutely repair. And then, of course, if you have concomitant meniscal and focal cartilage injuries, those you can manage them acutely. And these ones ensure a good long-term outcome. Single-stage surgery with repair and reconstruction of all torn collateral and cruciate ligaments may be appropriate for an acute high-grade injury in a young patient. That young patient must be capable of extensive supervised rehabilitation. Rehabilitation is very important. Acute knee dislocation, acute phase electric treatment. You can do single-stage open repair or augmentation, repair of collateral ligaments and reconstruction of cruciate ligaments, or you can do a staged ligament surgery. Acute phase, open repair, collaterals, followed by subsequent second stage arthroscopic reconstruction of the ACL, PCL. Or you can do acute phase immobilization, followed by delayed arthroscopic reconstruction of cruciate ligaments with open reconstruction of collateral ligaments. This is often done as a single stage procedure. That's a summary of the same. This is the anatomy Dr. Mutiso is showing there. Repair versus reconstruction. The theory is that you fix everything. So, cruciate ligaments, you repair, avulsions, reconstruct all the others. So, literature supports collateral ligament reconstruction over repair alone. You have a higher failure rate with PLC repair versus reconstruction by Laprade. There is higher return to sports with reconstruction versus conservative management. 29 versus 10. Reconstruction is better, you get better functional outcome from reconstruction than non-operative management. So far, we didn't have enough literature on augmentation. So, in general, we talk of you start with the peripheral structures first, then later you go reconstruct the inner ligaments. These are some of the reconstructions which have been covered. Now, rehab. Immediate range of motion exercises post-op with press 0 to 90 degrees, strengthening exercises, non-weight or partial weight on crutches. If there's a foot drop, you give them a foot drop split. And rehab usually extends in 9 to 12 months or even longer. So these are some outcome measures which you can test the patient on success. Now complications. Initial complications, you can have hemarthrosis, infection, another serious complication, arthrofibrosis. You can get problems with your tunnels. If you don't know where you're putting your tunnels, you can get tunnel confluence. So sometimes you need to put several tunnels to reconstruct all of them. We can get hardware failure, so graft failure, and of course secondary osteoarthritis would follow. So in summary, these injuries are rare, can be with or without dislocation. They are associated with polytrauma. There is high incidence of neurovascular complications. Acute stabilization, then delayed reconstruction 2 to 3 weeks later. Prolonged rehabilitation up to 9 to 12 months. A reminder of our upcoming workshop in Nairobi, 18th to 22nd of September. You are all welcome. Your security is assured, should not be worried. Thank you.
Yeah, so let's get the question. One is multi-ligament, then the EAA questions can answer. But you can answer on joining.
Yes, if you go to our website, there's a form you can fill. And also there's a link you can use to pay your membership. It's very straightforward. You don't need any referees.
The form I have, if you want, I can give it to you or have it on my lap. If you have a flash list, I can give you the form for registration for those who would be interested. Any other issues? Any other question? I think I hand it over back to you. The chair, Dr. Willa, will give the vote of thanks. And then I think we want to thank everybody. And of course, I must thank Dr. Nungu sincerely for hosting us and for making sure this event is very successful the way it has been. I mean, we were here many years ago, but this is much better than what we found when we were here in the year 2012. Yes, when arthroscopy was in its formative years, both here and even Nairobi. But now you can see we are already at the level of doing hip arthroscopy. Shoulder is very well established now in Nairobi. We are hoping that through EAA we'll be able to expand this knowledge skills across the East African region. That is our aim. So thank you very much, and hope to see most of you in Nairobi for our upcoming courses. Thank you so much.
I hope in this workshop, if you look at our booklet, our course objectives, I think you have 4 objectives. Determine the indications for diagnostic and objectives in arthroscopy. That's one of the objectives. Determine the port of entry points. Second objective, to gain confidence in the instruments of arthroscopy, and also to deepen knowledge of the instruments. Those were our 4 objectives, which I wrote in our booklet. I think that you have achieved, I presume so. And if you have achieved, please, there are evaluation forms. I'm requesting you all to fill them, so to fill that form so that we can know what you think about our workshop. But as before our chairman speaks, I would say also that there are many things which look like impossible, but like the last 2 topics, when he talked about the back side of the knee, but these are just things which we learn. Yes, it was a basic course, but there are many things which have been taken into account, like those 2 last topics, because they are very important. We also, I hope that you bear with us. We have our limitations. We would have liked to have instruments here for you to get acquainted with all these instruments, but we couldn't get someone who could come with the instruments so that you could see them. The things which they showed, for example, the RF machine, the angles, I mean, for determining angle for drilling or so. Some of you haven't seen them probably, but we couldn't get those things in place because of our limitations in our country, that there is no company in our country which could bring instruments for display. But I hope as we go forward, you'll see all these things. Also, at the same time, there are different implants which people talked about, we are talked about here, but you could see them all. And I think also such a things, as you go forward, you learn, you see them, you see them. However, also, from my side, as a local organizer, I'd like to thank our sponsors, the 4 sponsors who were talked about yesterday. But right now, instead of informative TV, really thank you for your support of being with us and trying to put us on the group. I would like to thank the participants because you responded to come. It's as if while I was in school, if you got someone who has prepared food for you, for people to eat, or for a party, if the people don't come to eat, then that food will go to waste. If you hadn't responded to coming to this workshop, all this effort would have gone into vain. So we really thank you for participating. I also very much thank the faculty which came the whole way from Nairobi help us or to organize to deal with this cause. I shouldn't forget about my organizing committee, which we have organized. We spent some time planning this, and it has come to reality. There's a lot behind it. When you see a groom going for the wedding, there is a lot of preparation for that wedding. So I thank my organizing committee. At the same time, I'd like to thank the Moya administration for giving us space, which includes the IT people who have been with us for these 2 days here, the mechanical section, the cleaners who are around, and not forgetting the catering services. So, from my side, I think that's all. I would like, after our chairman speaks, to give you certificates, your attendance certificates. Thank you. Some stocks of having this course running even next year. We'll see as make it in your comments, then we will see what we can do. Everything is possible.
Thank you, Nungu. I think Nungu has covered most of what I would like to cover. Ours is to encourage you to join us. And from our experience, this is the only way you learn. You start from scratch like this, but you pick up eventually from there. So hands-on is the only way. By seeing, even if you see, you go to wherever you're going and you work 100, it will still be a waste of time. You still need to start from the basics, and that is yourself. So this was a very good opportunity, especially the weight lab aspect. Thank most of the thanks have been done by Nungu, but we also wish to thank Professor Pondo for having found time to come and do the weight lab for you guys. And all of you. So we want to encourage you please to join us. Even when there's our meeting in Nairobi, you're welcome. And the EA would particularly like to thank the faculties, the international, the people from Nairobi and from England, Dr. Abid, Daniel Jude, and of course the three of you, Nungi, Marita, and Zakaria, and the executive director. We're very grateful. Well, we are happy as EAA for that. I think basically I will not repeat myself on these issues. We would like to finish maybe by
We honor everybody for attending. So we get your certificates. Please come around and get your certificate. I think it's the highlight of moment for that. I need to give up. Sorry. What? We can start with Aaron, Dr. Aaron Ndipo. Followed by Dr. Adam Hussein. Dr. Adam. Adam was very useful in the wet lab. Dr. Allen Kisanga. Dr. Benny Ajay. Then Dr. Baraka Stefano. Baraka Stefano. Dr. Christopher A. Paul. Dr. Dismas Cosmas.
Dismas Cosmas, Emmanuel Mlei, Felix Murita, Francis Fabian, Ferdinand Mjakili, Dr. Ikiri Martina, Goodshall Muringo, Dr. Imani Mombene, Imani is not there. Dr. Ruga Shekue, Dr. Helen M. Machake. She was the one doing the program and in charge of the catering and everything. Joseph Sabas, Dr. Jumbe Mohammed, Dr. Joseph Mwanga, John Chakula, John Chakula anakuja, Dr. Samuel Lungu, Dr. Lungu to present to kuchukua picha hiyo kale. Congratulations. Na Lugisio Rafael Mwakarukwa, Magdalena Beale, Magdalena Ayuba, Muhammad, Mark Lutomi, Mark ako kwa mkutano hapo nje. Maureen Samki, Dr. Maureen Samki, Dr. Muhumuza Neville, Nicholas Lubega, Dr. Gutu Meshak, ameshaenda. Penina Kagina, from Uganda. Dr. Pen Sama, Paul Nicolaus, Rahel Novika, Dr. Ronald Kale, Dr. Kale mpiga mwananchi. Kuna mtu paparazi Simon Boyo, Sebastian George. Sebastian George. Samuel Owinga. Sami Isha. Isa. Dr. Tito no. Vincent Mutiso. Wilson Masanja. Alafu Zawadi Mhumbuga. Zawadi Mhumbuga. Mimi kusahau jina langu. Natuma Ponde. About Mungu.
Thank you for the evening, and there is no any more activities going now this evening. Just that with our faculty will be together also. Yeah. Despite filling our evaluation form, depending on something you have to say right now, please. Any comment from anyone? Okay, thank you.
Yeah, but some of them I can't see. Yeah, but they're not all of them. Eh? You have yes for yesterday. Yesterday, who was for yesterday? Yeah. Do you use this computer? Use another one. Thank you. Very good. Well done, guys. Well done. Yesterday, I saw this meeting. You know, like a model. Is it here? Oh, so you have one around here. So, it's yours. It's so nice. So, when you're looking for it, you're able to have it. Thank you so much. I think I should go for a joke now.
Tanzania. Hii ni imeachwa leo jana hii.